Good morning.
Good morning, sir.
Sangeet.
Hi.
Yeah, it's 9 a.m., sir.
Okay. Good morning and welcome to the Bombay Orthopedic Society Master Series. And this time around, we have got a very exciting topic, a trauma topic, which will enthuse and interest all the general orthopedic surgeons, residents in training, fellows. And that is about a little bit of a controversial problem, and that is injuries around the shoulder girdle. For years together, when we were training, clavicle fractures were only never to be operated, and today the whole theme is changing. Fractures around the proximal humerus, one is always worried whether the outcome eventually will be a happy outcome or patient will complain of pain, stiffness with loss of motion. These things are changing dramatically as we understand, and better ways of fixation, better ways of operating these patients are done. Today, to enlighten us about injuries around the shoulder girdle, we have got very eminent faculty, not only from India, but from across the globe. And we have got two excellent young shoulder surgeons, trauma surgeons, Dr. Pradeep Nemade, who is Associate Professor of Orthopedics at the KEM Hospital in Bombay. And we've got Dr. Dipit Sahu, who is an assistant honorary, he's a shoulder surgeon. He's an assistant honorary at the Cooper Hospital in Bombay and is also a consultant shoulder surgeon at the Reliance HN Hospital and the Jupiter Hospital in Bombay. Welcome to this session. Wishing all of you a very, very happy 2021. And without much ado, I will hand over the mic to Dr. Nemade to introduce our eminent faculty and take you through the program. Thank you.
Very much, sir. So the entire program is divided into 4 sessions. The first session would be on the proximal humerus. Then we have a session on the clavicle, and we have a session on the scapular girdle. And in the last, we'll have some case discussion. Each session will be having 4 talks of 10 minutes each, and then we have around 15 to 20 minutes of discussion. The first session is focusing on the proximal humerus fracture. So the program is not actually to have a comprehensive overview, but to discuss the current controversies and the needs and nitty-gritties of the proximal humerus fracture management. So we have 4 talks in this. Dr. Ashish Fadnis is going to take us through the current concepts in classification, from needs classification to the current understanding of the proximal humerus fracture. There has been great revolution. And what are the current concepts? Dr. Ashish Fadnis is going to take us through. He's a consultant orthopedic surgeon from Thane. We have Dr. Ashfaq Hassan, the associate professor of shoulder and elbow from the Maryland, United States of America. And he's going to take us through on the most important aspect, that is the decision making of proximal humerus fracture. I would try to shed some light on the pattern-based reduction techniques of proximal humerus. And Dr. Dhaval Desai, consultant orthopedic surgeon from Surat, is going to take us through the augmentation of proximal humerus fracture and troubleshooting of the problems. So without further delay, I would like to invite Dr. Ashish Fadnis to take us through the classification of proximal humerus. Have we decided yet on classifying proximal humerus fracture? Over to you, Ashish.
Thank you. Right. Thank you very much to Dr. Pradeep and Dr. Dipit Sahu, who are very dear friends. And thank you very much to Dr. Gautam Zaveri and the Bombay Orthopedic Society for having us here in this morning to discuss about the shoulder fractures. As Dr. Nemade said, I've got a classification talk, which I will try to make it a bit interesting. But this is more of a philosophical talk as to really question ourselves whether we are all looking at the same thing. So when we talk to our colleagues or when we talk to our residents or any other orthopedic surgeons or therapists, the way we describe a fracture communicates a lot. Now you can see this images, basically an osteoporotic shattered proximal humerus fracture and a young patient with a proximal humeral fracture, they are not necessarily comparable, will have a completely different set of complications, which have a completely different set of outcomes. So we needed a universal language to communicate with our peers, to compare our results as is described in literature, or to compare it to the known standard. The way we talk about displacements of fractures in a younger individual and an elderly individual also have their own set of problems and also have their own set of challenges. And this was being tried to be addressed in the different classifications that we have known over time. If you look at it philosophically, Codman had described in 1935 the four components of a proximal humeral fracture, which were the greater tuberosity, lesser tuberosity, head, and the shaft fragment. And the most popular classifications, which is the NEER, the AOOTA, and the Hurtle's classification, which is now becoming very popular, are basing their concepts and basing their classifications on the original Codman's concept. So the NEER classification went through certain changes. It was initially described in the 1970s, modified in the 1975, and again modified with addition of certain components in 2002. The AOOTA classification was described in 1987 or 1990, but it was recently modified in 2007 to add certain modifiers. What those are, we will see in the next few slides. The Hurtle's classification, though it's a relatively newer classification, even that went on certain addition within a short span of time. And he had, so Hurtle is from Switzerland, so he had his neighbors from Italy and Spain who are adding on certain more aspects to this classification. So as I mentioned before, this Codman classification describes these four different components. We are in the master series, so I will not dwell on the individual nitty-gritties of these classification, but to give you an idea, the Neers borrowed this concept and described his four-segment classification, which came up with 16 subtypes of this proximal humeral fractures. It is later on modified to include a few more things. Now, interestingly, what we remember from the Neers classification and what everyone tends to remember from the Neers classification is the definition of a part is that the part which is displaced more than 1 centimeter and angulated more than 45 degrees. Now, a bit of trivia is that this is a completely arbitrary figure that Neers himself has written in a letter to the editor that, I've just come up with this arbitrary figure because you wanted me to put a figure as what a displacement is. But a surgeon should never hold it like, it's 10 millimeters displaced, so it's this type, and it is 8 millimeters displaced, so it's not displaced. So it's not a dogmatically held belief that, you should have these measurements per se, but this is a rough guide to a surgeon. Therefore, it led to a lot of sort of difference of opinion between the different investigators and different surgeons also, how they interpreted the Neers classification. The AOOTA is an alphanumeric classification which deals with whether it's an extra-articular unifocal, bifocal, or an articular fracture. And as in the most recent modification, they have added certain qualifiers and universal qualifiers. So other than it being a type A, B, C, and a subtype 1, 2, 3, they've also added letters like X, Y, and N to modify it. These are the two most popular classifications. So when you read a paper, when you're reading a Profer trial or any other trial which are dealing with proximal humeral fractures, we see that they describe Neers type and an AO type of these fractures and they compare the treatments. But are these really comparable? Now, this is a very good paper which has come from Sweden, and this is a shoulder surgeon who has tried to see, is there a translation or do we need to understand both the classification? In short, do we need to be bilingual to understand both these problems? So this is a very busy sort of table, but if you want to eyeball it, whatever is there in green is good. So on the left-hand side, there are the AOOTA subgroups in type A, and on the top is the Neers subclassification. And you can see that if the boxes which are shaded in green means that the AO subtype and the Neers, they have a particular agreement. But the ones in the yellow and the red, which means that they do not have an agreement. So for example, if you're trying to describe a particular fracture or a fracture subtype in Neers classification, that may not necessarily be sort of, applicable. So a unifocal extra-articular fracture of AOA, like let's say 1, 2, may not necessarily be a Neers type 2 fracture. So it could be something else. So we have to be more descriptive than that. And this is the same thing is shown in type B fractures and the type C fractures. Now, this was all anatomy. So we are discussing the anatomical things that we see, the different parts that we can see. But we know that when you are healing a fracture, there is more to the anatomy than just anatomy. So there is a mechanobiology which we look at. We look at whether the mechanics of the fracture, whether the fragments are individually displaced, whether they're angulated, whether they're impacted, and ultimately the biology, the quality of the bone and the blood supply. So this is where these two classifications fall short, and this is where the new Hurtel's classification comes in. So Hurtel has borrowed his concept again from Codman. Again, he describes 4 different fracture types and 5 different fracture lines which run through them. So it is a binary classification where they keep on asking questions whether there is a fracture between the tuberosity and the head, tuberosity and the shaft, and so on and so forth. So it basically is a yes and a no classification. And based on this, they came up with a criteria as to predict when the human head will have a problem with ischemia, what would be the blood supply be, and therefore it is a classification which can aid your management in salvaging the head, or whether you need to go in for a replacement. So this was a relatively useful classification. However, there were certain issues which are again not sort of addressed in that. So Hurtel's neighbor from, let's say, from Austria, Herbert Resch, he added an addendum to the Hurtel classification, and this is a paper which has got authors from England, from Stockholm, from Sweden, Austria, Switzerland, all over, and they sort of added certain modifiers or certain addendums to the Hurtel's classification. And here we are again talking about the biomechanics. So we are talking whether whether the bone broke in impaction, in distraction, whether there are tension force at, or whether there was a varus displacement, valgus displacement, and if the fracture fragments are right now lying in flexion or extension. Because all these and the displacements of the fracture have an impact on basically the healing of the fracture and the blood supply. But was the Hurtel's criteria the final word? His neighbors in Italy then came up with this concept of the metaphyseal torus. Now they said that there was not a significant, there was a correlation, but it was, again, there were certain fractures which were not following the Hurtel's rule of a 8 millimeter metaphyseal beak, of a displacement which was less than a particular amount, of an impaction particular fracture. And so they came up with this idea of a metaphyseal torus, where they talk about the anterior and posterior circumflex humeral arteries and whether the fracture has broken into a compression or a distraction. And they have floated the concept of angiosomes, which essentially is the same similar concept to what Codman had described. And 4 zones, 4 angiosomes, and the interplay of these fractures. So now let us come to the reliability of this classification. Now we know historically that reliability of the inter and intra-observer reliability of the NIRS classification is questionable. But the advocates of the NIR classification, they said it is the training. So higher the grade of the surgeon or the more experienced the surgeon is, more reliable is this classification. If you add on the CT scans and the X-rays, the classification becomes more sensitive. However, this is classified in the emergency room based on the AP lateral and the sort of the trauma series X-rays, which is determined by the pain of the patient. The patient holds a particular arm in a particular position. And also it depends on as I said, the experience of the surgeon. Even when this NIRS classification was shown to the artificial intelligence, or people are trying to sort of marry these radiology modalities, diagnostic modalities with artificial intelligence, there is a poor inter-observer and an intra-observer correlation of the NIRS classification, especially in the 3-part and the 4-part fracture. When you compare the NIRS to the AO classification, when you compare the Hurtel's to the other classification and the AOT classification, I can just say in certain that the Hurtel's has a better inter and intra-observer reliability and reproducibility, marginally better than the AO, which is slightly more better than the NIRS classification. So I will not go into the figures here, but if you have to rely, the AO is a more reproducible classification. The Hurtel's is a more understandable. It's a bit tedious, but it is more reliable in terms of reproducibility in describing a particular fracture. So as we observe the classifications, they do not obtain a good reliability, and therefore we are basing our treatment options and we are basing our comparative studies on these particular classifications, which itself are not reliable. So can we basically rely on the outcomes or the conclusions of the research papers which are being produced? The good news is, so it's all not gloom and doom. The good news, however, of these papers is that the surgeons do not have an agreement on the classification, but when it comes to treatment, the surgeons are in agreement. So Stig Borsson, a lot of work is done by these Swedish guys, Stig Borsson. So what he says is basically, if you give a particular X-ray on 2 particular occasions to 2 surgeons, they may not necessarily agree on the classification. Both the times they might come up with a different sort of a grade of the fracture, but more often than not, they would agree on what is to be done for this particular patient. So here we look at our classification systems, and there was a debate in the orthopedic community on, they assessed all the they classified the fracture classifications. So basically into a few types. Now let's look at a good classification is like a grade A, where you have 4 different types, 1, 2, 3, 4, and it has 4 different treatment options, A, B, C, and D. So this is a very good classification because this classification tells you how to treat the particular fracture. The next one is a grade P, in which there are 3 types of fractures, and you would have certain treatment options. Like grade 1 will be, a particular treatment. Grade 2 of this particular fracture will have this particular treatment. But when you come to the shoulder fractures, as also a lot of other orthopedic classification, the type of, let's say, type 1 to type 4 of the knees does not necessarily mean a particular treatment or a B particular treatment. So you can treat any fracture with any modality. So this basically doesn't make much sense when someone, a neutral observer, is looking at a particular classification to guide him with a particular treatment. So these are not, they were not necessarily bad designed classification, but it basically, the treatment options of treating these fractures, they evolved so rapidly that our classification probably were not able to keep up with the pace. So Christian Gerber, in his review of this article, he also has said the same thing, that these fracture classification, they have failed to show that a fracture belonging to a particular category has a distinctly different prognosis and will require a different treatment or a different outcome. This is particularly true about all the classification systems in the shoulder fractures. So the Spanish have come up with a new classification in which they take everything into consideration. It's a very tedious classification. Again, it's a binary classification. But what happens is that when you try, this is slightly my opinion also mixed in, when you try to include a lot of factors or even a moderate number of factors, it produces a system which is too complex to use. And the glaring example is the AO classification. So a research classification contributes to its own demise as a clinical classification. So the more variables or factors you have in a particular classification, it becomes too complex to be used by a ordinary layman who's working in the casualty, not a layman, ordinary resident or a surgeon who's working in the casualty or in front of the patient at that particular time. So the need for completeness, it conflicts with the clinical use or the interest of the clinicians. To conclude, what I would say is basically I like the NIRS classification because very simple classification. It tells you very easily that it has divided the proximal humerus into 4 broad fragments which can be communicable very easily. So if it is my trainee who needs to understand the deforming forces, or my registrar who needs to tell a particular treatment, the NIRS classification, I find it a bit useful. If I have to receive a phone call from a registrar in the middle of the night, then I would prefer him to be telling me as to, it's a type 3 fracture or a type 4 NIRS fracture which I am admitting. The same registrar, if he has to write his thesis or we have to submit this for coding or billing purposes, the AO-OTA classification becomes very useful because it's a more comprehensive and more reliable classification when it comes to reproducibility. At the same time, if you want to make a decision regarding whether you're going to fix this particular fracture or you're going to replace this particular fracture, then the Hertel's criteria, it comes and helps you make a clinical decision. So I think, to conclude, we have not arrived at one particular classification. We definitely need to be bilingual or know more than one particular classification in treating these fractures, which span across the spectrum between a young patient to an elderly osteoporotic lady, where the gamut of complications and the clinical challenges are completely different and very varied. Thank you very much.
I think we can move on to the next talk.
Yeah, thank you, Ashish. That was a lovely talk. Can we move on to the next talk from Dr.
Can you stop sharing?
I have stopped share. Is it working now?
Yeah. Dr. Hassan can share his screen now.
Yeah, okay. I couldn't share earlier, but let me try it again. Okay. Can you guys see my screen?
Yep.
All right, great. All right. Well, good morning, I guess, everybody over there in Bombay. Thanks for inviting me. I think this is, I'm happy to be part of this, this meeting. So I'm going to talk a little about decision-making in proximal humerus fractures and sort of go through some of the issues with this fracture pattern. And really the essential question that is seen to be a bigger issue nowadays is, do proximal humerus fractures in elderly individuals require surgery? Do we actually need to operate on these fractures, or can we just treat these non-operatively? I think that's a separate question from the younger active individual, of course. And, there's, as you all know, there's significant evidence that's been published recently arguing for non-op management. The PROFER trial, which was published in a very high impact journal, JAMA, in 2015, the Cochrane review also in 2015, and both concluded essentially that in terms of shoulder function and quality of life, operative management does not appear to be more effective than operative treatment for proximal humerus fractures, especially in the elderly. And this is subsequently supported by several meta-analyses supporting these conclusions. Now, there of course are issues with the PROFER trial. One is that patients were excluded if they had clear surgical indications or had a dislocation. Less than 5% of these were 4-part fractures, and 66 surgeons operated on 125 patients over a 2-year period that the study was done. And so that basically comes out to less than 1 patient per year per surgeon. And if you also look at if you really dive into the paper, about 82% of the cases were done by the consultant surgeon, and it suggests at least that 18% of the cases were done by registrars, as I guess they're called in the UK, or residents. And arguably these fractures are some of the more difficult ones to operate on. So you have a low volume of cases being done by many surgeons, and really for people who arguably were on the border whether or not they needed surgery, right? Because they excluded the people that had clear surgical indications. So I think you have to take this with a grain of salt in terms of their conclusions. Unfortunately, this had a huge, well, I don't know if it's unfortunately is the right word, but this clearly had a huge impact, especially in the States, I'm sure, around the world. But having said all that, I mean, the PROFER trial still, I think, is an important publication because it did highlight even more so than we already were aware of the fact that a lot of these fractures can, in fact, be treated non-operatively. So what are the indications for operating in an older individual? Well, the obvious ones were vascular injury, humeral head dislocation, non-unions or delayed unions, and then we get in that category of severely displaced, right? So now we're talking about the near 3s and 4s, and that can be, there's a lot of other factors that go into that, right? So certainly the patient's overall health, as well as the patient's functional demands go into that decision-making process about whether or not they'd be better treated by surgery. How was their shoulder function before they hurt this? Do they have a shoulder that only elevated to maybe 90 degrees beforehand? So these are all important factors about whether or not you operate in the elderly individual. And of course, these are different type of fractures and the various rough percentages of them. We'll sort of go through a couple of them, a couple of different categories, and then talk about a little bit about reverse arthroplasty. So 2-part surgical neck, of course, most of these can be treated non-operatively. If you're going to go down the surgical route, percutaneous pinning, again, that may be, with the osteoporotic bone, you may want to be careful with that. Lock plating and or IM nails. I'm not really a fan of IM nails, but I would probably do a lock plating if I had to do anything. This is just a typical example. This is a 75-year-old woman, mechanical fall, and you can see he's got some medial shaft displacement, but the head is well centered. The tuberosity, there may be a fracture line there, but it's certainly not displaced. And so this is one that can be very successfully treated non-operatively. And this is her 1 year post-op, absolutely no pain, full range of motion. She says she has no limitation in what she wants to do. She actually just came back because she fell and broke the clavicle on the other side, so she came back to see me. But very happy with the result there. Two-part graded tuberosity fractures. Now these, of course, minimally and non-displaced can be treated non-operatively, of course. One thing to remember, and these get stiff very quickly, so we want to mobilize them quickly because they will get very stiff very quickly. If it's secondary fracture dislocation, with a wide separation, especially in a more younger patient, then you do have to watch those for redisplacement, even if it's anatomically positioned after reduction of the joint. So now this is a patient, maybe other end of the spectrum of how you treat them. This is an 89-year-old woman. She came to me 2.5 months after her injury, and she had a simple fall. I think she was out gardening and she fell. And this is what she has. So she has this, and she's being followed by another orthopedic surgeon who elected to treat her non-operatively. And she was not happy. She said, my shoulder was normal. Now I can't move my shoulder, hurts all the time. And as you can imagine, based on these x-rays with that significantly posteriorly displaced tuberosity fragment, she had very poor function. And I think probably, her age was one of the reasons that non-operative management was chosen in her. But, I think as we can all agree that, it's really more their physiologic age and their functional age as opposed to a chronologic age. And this individual was active and healthy. So we took her to the OR and mobilized the fragment, got a fairly anatomic reduction. And she doesn't have perfect motion. She's about 4 months out now. Active elevation is 130 degrees. External rotation is about 35, but she has no pain, and her motion continues to progress. So the reason I showed this case is I think that in the rush to say we should non-op all proximal fractures in the elderly, I think that we have to look at the fracture pattern, and when we talk to the residents, talk about their functional level and their overall medical status before you just blankly or blindly put everything in a non-op protocol. 3 and 4 part fractures. Again, just briefly, you guys all know these treatment options for these fractures. This was a 76-year-old woman. Again, a simple fall, and another very active individual. And she came basically saying that I want my shoulder to be completely normal, and I'm very active, and I want a surgery. And she'd come from another surgeon who would also recommend a surgery. I saw her and I said, look, I don't think this needs surgery. I mean, this is just mildly displaced. Tuberosity still below the head on the Gracie. And we treated this non-op, and although she wasn't particularly happy about that, actually. But this is her at about 4 months, and you can see solid healing, and her range of motion is already at 4 months out is close to normal. This is the other end of the spectrum. Bad fracture dislocation, 50-year-old male, motorcycle accident, a little bit of a different patient population, obviously younger, active gentleman, and with a bad. And this, I apologize, I don't have I thought we'd loaded in the some orthogonal views here, but I guess we just have these 2 views. But had a 3-part significantly displaced fracture, and that did well with lock plating. And that was actually a case of my partners at when this guy came in. So switching gears, I just want to touch a little bit on reverse shoulder arthroplasty for proximal humerus fractures. I think this is an area that I think there's certainly a big trend towards, certainly in the States anyway. And the indications are evolving. But I think that, in my hands, 3 and 4 part proximal humerus fractures in elderly patients. And you say, what is elderly? Well, I think if you ask 5 surgeons, you may get 5 different answers on that answer. But I would argue that really once you get 65 and above, you've got to start thinking about reverse. Certainly if they have severe graded tuberosity, significant graded tuberosity comminution, and if they have a history of prior shoulder dysfunction. So that's one of the first questions I ask them. Hey, look, how did your shoulder function before you hurt it? Did you have a normal function? Do you have any shoulder pain? Did you have night pain? Something that would suggest some underlying cup pathology in these elderly patients. which of course, as we know, most of them have some degenerative tear. And then and these people usually end up with CT scans, and you can get a lot of information on the CT scan as to what the rotator cuff muscle, how much atrophy and how much fatty infiltration, and that can help guide your decision making about which way to go. And I'm going to leave ORIF out of this, talking about people who we think who are not ORIF candidates. But so looking at hemiarthroplasty, which we did a lot of those, right? And got reasonable results. But the problem with that, it was unpredictable. You could have a great outcome in the hemiarthroplasty. People have great motion, full motion, good external rotation, but then you can have some horrible outcomes. And this was a very good systematic review published in JBJ's British. And they found tuberosity complications in 11%. Mean CONS score is only 56. And most had really no pain or mild pain, but it had marked limitation of function. And their conclusion was that a normal function shoulder after hemiarthroplasty for fracture is generally unachievable, even with an appropriately structured postoperative program of rehabilitation. And I think we all know the challenges with the hemiarthroplasty, getting your head height right, getting your tuberosities adequately reduced, getting your retroversion correct, and all those things can lead to a really poor outcome if the tuberosity fails. And hence the push towards doing reverse. Early results in reverse, this is one of the earliest studies, a very small study, only 16 patients. The constant score wasn't that great. And that's probably attributable to the fact that they didn't fix the tuberosities, essentially, except for maybe 5 patients. They basically resected the tuberosities. And so, of course, that would result in very poor rotational motion and affected their outcomes. This is a good prospective randomized trial, randomized reverse versus hemiarthroplasty, and showed that reverse had better pain, function, low revision rate, and revision. And if you did revision from hemiarthroplasty to reverse, it really did not improve their function. So you're better off doing the reverse as a primary operation and not the hemiarthroplasty. So just a couple of quick case examples. This is a 77-year-old male. He came 4 weeks after this injury. He fell off his bicycle. And you can see he's got this locked posterior dislocation with a large reverse Hill-Sachs lesion, really probably about 40% of the head, and had a reverse put in. Similarly, this 72-year-old woman who tripped off their back deck and into her yard. And she said that, my shoulder wasn't perfect beforehand, but it was okay, but I had some pain. And she has this highly comminuted fracture. You can see the graded tuberosity is highly comminuted. And she ended up with the reverse and had excellent range of motion post-op. So if you're going to do reverse, so of course it's critical to restore your humeral length and get your tuberosity anatomically aligned. There's a couple different ways you can do this. I like to measure the graded tuberosity height on the pre-op CT. And I also do intraoperative measurement to verify that. You can measure around the calcar on the head segment. And usually you have almost invariably behind the bicipital groove, you have a triangular fracture pattern right behind the bicipital groove, which you can fit the graded tuberosity in and get an anatomic reduction. Multiplanar fixation. You got to be careful when you're reducing these because it's going to be a little bit, it's going to have a little looser feel in the primary when you're reducing because the tuberosities are still off. And so you cannot make it, you can't make it snug the initial reduction, because if you do, you'll over tighten them. They'll have pain, and they could even have an extra nerve neuropraxia. But if you get a good, get good tuberosity fixation, I'll fix a greater and a lesser to allow for good restoration of rotation. And it appears to have, based on literature and based on our results, much more predictable results than hemiarthroplasty. Thanks.
Thank you very much, Dr. Hassan. We are going to take the questions at the end of all 4 talks. So I'm going to go through with the next talk, that is the pattern-based reduction of proximal humerus fractures. Okay. So that's the place where I work, that's KM Hospital. this is the article which I stumbled upon a few years ago, though this article do not basically describe the reduction techniques, but I was pretty fascinated by which the way which they have actually classified the fracture pattern fractures based on the patterns in which they present to us. So the authors classify this fracture into 6 different patterns, and I think that has helped me in during the surgery, though the author do not describe that much in the article per se, but understanding this pattern definitely helps us in reducing this fracture. So the first and foremost, simplest most is the posteromedial impaction fracture, where the fracture goes into varus and extension. The second thing is that we have posteromedial impaction, but in addition to that, we have separate lesser and greater tuberosity fragment. Another is where we have the fracture of the lesser tuberosity remain intact, but just the greater tuberosity fractures, and there is a posteromedial impaction fracture. So this fracture, the lesser tuberosity and subscapularis remains intact with the proximal humerus fracture. The fourth pattern is the valgus impaction fracture, that is the fracture, the lateral impaction, and both the tuberosity may be fractured. Sometimes it can be only one tuberosity, other tuberosity just tilted. Fracture of the greater tuberosity is a separate pattern, and one of the rare pattern is the anteromedial impaction pattern. So in this talk, I'm going to focus on the first 4 patterns. The 5th pattern, that is the greater tuberosity, is altogether different talk, and 6 I have omitted because of the rarity and simplicity of that. So focusing on the first, posteromedial impaction fracture. So we have standard teaching of the AO that we need to get a hold of the proximal humerus either with a joystick of K-wire. We can have sutures in the tuberosity to control, or we can have a jacking open type of reduction using some kind of osteotome. So if you see this kind of a case, a very simple kind of case in a young patient, fracture of proximal humerus, and we can see that this is a typically entire fracture has tilted into posteromedial direction. The shaft is trying to come out entirely. So this fracture, we need to understand that there is a varus as well as there is the extension. So if we try to pass our reducing osteotome or a joker, it needs to be from the anterolateral aspect, not from the pure lateral aspect. So if we pass it by pure lateral aspect, then we will not be able to reduce the extension of the fracture. So the joystick needs to go just by the sides of the side of the bicep tendon, and when we try to pass it to the pass it completely on the medial edge of the fracture, and then we try to lift it up, the fracture get reduced. While doing so, we have to have control over the tuberosity by the sutures, and thus we can get the beautiful reduction at the end of the maneuver. So this can be fixed again with 2 K-wires, and plate fixation can be done. So this is the simplistic method of reduction of a very simple posteromedial impaction fracture. And then again, it can be neutralized with the typical Philos plate or whatever method of neutralization that the surgeon prefers. One more thing that we need to take into consideration is the sagittal alignment. That many a times, because these fractures are done into bichair position or supine position, which I prefer, now the elbow tends to drag down because of the gravity, and then the entire fracture can be fixed in little bit of extension position, and we don't want that. So while reducing this thing, while putting the plate, we need to get this light bulb view where the shaft is centralized over the head is centralized over the shaft like a bird or like a light bulb. And if that is creating if there is a residual extension, then a plain L punch can be kept here, and the elbow can be flexed, a shoulder can be flexed to reduce the residual extension of the fracture site. This article mentions the neutralization of the pectoralis pull if the shaft is dislocated, displaced medially. However, it rarely happens that the shaft is displaced medially. More often than not, the head is tilting medially, and if we try to reduce this fracture and by a simple screw like this, so in this case it was reduced, and then when we try to push the screw, the shaft can get a little bit medialized like that. And when we get that medialization, the medial contact get lost, and there is a cortical to cancellous contact, and then that can cause problem in the future. So one of the technique by which this can be prevented is by use of a push screw method. So if this fracture, if you see, there's a little bit of comminution there. So we need to see that the proximal humerus is conical shape. So little bit of comminution at the base of the medial side, the ratio of the proximal and distal fragment is going to mismatch, and if you pull it completely laterally, then the medial contact is going to get lost. So to that the shaft need to be actually little bit medialized so that we get adequate contact. And sometimes after reduction, this residual varus is very difficult and very resistant to get corrected. So another trick of doing it is, to pass a screw here in the plate. Don't drill it, just pass a screw while application of the plate, so the plate remains off laterally. So that is contrary to the traditional teaching that the locking plate cannot be used as a reduction tool. Here we have used the locking plate as a reduction tool by putting a screw there of varying length depending upon your varus, so that the plate can be kept off little bit distally. After that done, we can pass the proximal screws, and then we try to pass this screw, the proximal screw. And after that, this screw can again be used as a push screw. At the same time, abducting the arm, we can get a good medial contact. So this is the use of locking, unthreaded undrilled locking screw and a push screw method to get desired valgus and medial contact in such recalcitrant fractures where their medial contact and the varus correction can be difficult. And that's the post-op result, post-op X-ray of the patient. Now coming to the second and third pattern, I'm going to club them together. That is the post-medial impact with tuberosity fragment. So now in the first fragment, we have good tuberosity control, that the sutures in the tuberosity are going to control the head also. Now in this pattern, since the tuberosity are separated than the head, then the tuberosity control are not going to control the head. The head needs to be tackled separately. So same here. So the issue here is the tuberosity control, correction of varus, reduction of the head if it is dislocated, medial contact, and of course the sagittal alignment that needs to be checked. So this case, if you see, there is a fracture of the head and the tuberosity are badly shattered. The head has gone posteriorly again. There is a comminution there, and the tuberosity are badly shattered. So in this case, the first and foremost thing that you need to do is to do a bicipital tenotomy, a partial release of pectoralis major. So these two things can make your life very easy. Then the third thing, that we can work through the fracture site to go to the head. So that's how we are working through the fracture site. We can see that glenoid and the head is anteriorly, and the head can be very well reduced after this. So after we are working through the fracture site, the head can be easily manipulated. Yes. And it can be reduced very well. And again, we can reduce it. Now again, see that because of the comminution, by putting the simple screw shaft get lateralized, and we don't have good medial contact. Again, we can use this push screw method. We can push the shaft laterally and we can get medial contact, and then the final result can be good. If we are getting a medial contact, the fracture can be reduced in slightly valgus position. Fracture dislocation, some fracture dislocation are pretty simple to reduce and some are pretty difficult, and the reason for that is because of whether the rotator interval, the continuity of the supraspinatus and the subscapularis is maintained or not. I'll come to that later. So this fracture, the head, if you can see that it is basically three-dimensionally jam-packed distally. So this is, since this is a multiplanar locking, they can sometimes be difficult to reduce. However, after reduction, we can put a plate and it can be reduced. So how to reduce? So another case where we can see that the head is dislocated medially. So first and foremost thing that we need to do is to do a bicipital tenotomy, and we need to do something called as a rotator interval release. After rotator interval release, head can be reduced. Labral repair is little bit debatable. If required, that can be done. And again, we can pass these two screws medially to fix this fracture, and ultimate reduction is like that. So the technique of rotator interval release, again, this is what I was talking. So if you see this fracture, that is the head is gone, is anteriorly also and inferiorly also. This is in two planes the head get jammed, and it's little bit difficult to reduce because the subscapularis and the supraspinatus, that continuity, that is the rotator interval continuity. So this area, this ligament, the musculoligamentous sleeve is pretty broad when the head is normal in place, but when the head subluxates medially, it forms a noose like this. So it's very difficult to take the head back, especially when it is jammed, if we maintain this noose. So to do that, we need to do a rotator interval release. So find out the bicipital tendon, trace the bicipital tendon and just snip the rotator interval release. We may not be needed to do, may not need to do a subscapular stenotomy. So we can maintain the subscapulates just by doing a rotator interval tenotomy, the rotator interval release, this reduction will come. So that's the fracture site. That's the bicep tendon. So that's GT. And anterior to the bicep tendon would be the piece of LT. So that's the LT. Yes, yeah, and we can just take our scissor along the bicep tendon and release the rotator interval like this. After we have taken rotator interval release, we can have the suture over the subscapularis and try to pull it anteriorly. It's not if we pull it laterally, the fragment further externally rotates and it further locks, so it doesn't get reduced. So we need to pull it anteriorly to basically decrease the jump distance of the head, and after that we need to pass some joker or a blunt instrument like that and try to just squeeze, just walk the head over the anterior aspect of the glenoid. And it's very important that we pull it anteriorly and not laterally, and then the head can get reduced very well. So in matter of seconds the head get reduced by this maneuver, and then further reduction can be done. Once the head falls in place, rest of the reduction becomes very easy. That's the GT. We can tie them off with the sutures like this. We can tie them off so that that ease a lot in plate placement and further reduction. And after that, further reduction can be done with whatever plate or the method of choice of this surgeon. I use plate in almost all surgeries. That's the reduction. So another case where if you see now, this is a head split fracture and the head is totally devoid of any capsular or muscular attachment here, and the head goes further medially, the tuberosity completely overlaps this disc. And now in this case, controlling this complete cartilaginous portion of the head is very difficult, and here the two Shanks pin two Steinmann pin are very useful. Of course, first we need to reduce the tuberosity. So again we have to work through the fracture site, that the LT, that the GT, and that's the head. So we reduce it temporarily, and with the two Shanks pin we can just dial the head in the desired position, and then we can basically fix this fragment like that. So that's how the reduction can be obtained. And because in case there is little bit the combination, the GT may tend to fall down, and in that case we have to elevate the GT and put some bone graft there, so that the GT remains up. Otherwise it tends to drag down in that comminuted portion or heel saccage lesion of the humeral head. And that's the reduction, and that's the final outcome at the end of 1 year. Lateral impaction fractures. So in this case, there is either the medial hinge will be maintained or it will not be maintained. So depending upon, we need to reduce. So in case the medial hinge is maintained, we do not need to do much. We just need to basically separate the tuberosity and lift the head up. We don't need to go medially because the medial hinge is already intact, and such reduction is very, very helpful if we just put some L punch or a mixture kind of instrument and just push the head laterally, and just when the head goes down, we just need to clamp the tuberosity and the entire reduction will fall into place. A similar case, this is typical fractures in the elderly. The head falls into valgus. We just need to make sure that this part of the head goes here. So just again, just put a small L punch kind of instrument, lift it up. If required, take a joystick, help of joystick, and then it can be reduced and very well fixed with the plate. So take home message, there are specific fracture pattern which needs to be recognized before you want to go in. Reduction methods are different for each fracture pattern. Overzealous traction is almost never required. Partial release of pectoralis major and deltoid insertion makes life very easy, and reduction tools are very important. Thank you. So after this, I invite Dr. Dhaval Desai because though this is very straightforward, sometimes the things can go out of hand, and that's when we need to do augmentation of fixation, or sometimes specific problem needs specific troubleshooting. I call upon Dr. Dhaval Desai to enlighten us through this aspect.
Okay. I'm here now.
Yes, we can hear you. We can
Yeah,
hear you.
good. Yeah. Good morning, everybody. Thank you, BOS and Pradeep. So, having heard Ashish, I think I like the Hertel Suktankar classification because I think the problem of proximal humerus is about a head, two tuberosities and shaft, and it's the story of putting it back right in. And then I think trying to keep the arthroplasty surgeons away from your heels, because I think the best place, after seeing Pradeep's talk, I think the best place for the head probably still is in the glenoid. Okay. However, this is a fracture that has variable outcomes. You cannot predict which one is going to do how, and of course, there's a high rate of complications. So everything that you do is geared up to restore the anatomy as best as possible, and then finally, but most important, is getting a good functional outcome, which is also an essential part of the treatment. Okay. Failure is fairly high, almost up to 30-35%, and failures are from all modalities of treatment. So even the best of the newer clever reverse can give you problems. But we will try, focus our attention in this talk on the fractures where there is a need to support the head because of our bone quality in the head. Sometimes there is a loss of medial cord support because of fracture combination. These are areas where these are likelihood of failure is higher. And of course, the reduction remains always a key, and one must try and achieve an anatomical reduction as far as possible. Okay. Getting a good reduction is definitely the first and the foremost key steps. We have seen from the previous talk, there are different maneuvers and ways to get it. Every surgeon has his stone, but I think restoring the calcar area is very important, and getting good subchondral purchase of screws again is the key area, along with the role of calcar screws, which have been shown in studies that they have a function in restoring the neck shaft angle and maintaining the neck shaft angle. Okay. Again, it's important to get and achieve reduction. And reduction, again, as I said, in any other fracture, it remains the reduction remains the key. What challenges you in some cases is whether this reduction is going to be maintained by whatever you have fixed. And if not, then that decision on table needs to be taken is to whether, what do you need to do to hold on to this reduction or decrease the incidence of failure of this reduction. Okay. And I think as one of the hands is in your hands is the calcar screws, which are a good adjunct, and it has been shown in research that they are the important part or armamentarium of maintaining your calcar neck shaft angle, and a good valgus to sustain your preventing your so the major issues are of secondary collapse or the screw cutout, which is one you want to prevent or fail. Okay. And as I said before, the calcar screws have so we come down to then when do you think about augmentation, and then really what are your options? And looking up at most of the literature, I think your hands are you have two things that have shown to at least work or promising. One is the medial calcar support with the use of fibula and the use of cement. I think these are two things that have only so far shown. People have tried many other things, including medial plates or even other fancier things. But I think these are the two important areas of research that are currently undergoing. And we should try and understand how they have been shown and what is their current status. Okay. Basically, we want to avoid failures because failures are a higher part of proximal humeral fracture, and especially in the elderly population where the bone quality and density is not working in your favor to hold on to the reduction that you have so worked hard to achieve, as what Pradeep has showed. Okay. Augmentation definitely improves biomechanical strength. Research evidence in most cadaveric studies have shown that whatever methods they use, the biomechanical strength of construct has definitely improved to sometimes, double the strength, especially with fibula. And the clinical outcome studies are mixed. We are seeing that there is definitely the role of augmentation in some situations, but still we need to work in our mind. It's important to remember that if you need support once you've done the reduction, but not fix the fracture, then probably I think bone graft substitutes are better than the use of cement. So I think once you fix, I think, and once you got your screws and plates in, and I think then the cement works better. So this is a broad concept that needs to be kept in mind, and this is very important in the case of voids that you need to fill before getting the reduction. Otherwise, the reduction may not be maintained. Okay. Two cements used commonly: calcium phosphate and sulfate. Calcium phosphate has superior edge, I think, because it has better strength in compression. I think it dissolves slowly, and this is one which is favored. In our situation, I think it's important to remember, it would probably add to a tremendous cost, I think, because these are not cheap. So I think if you need and when to need to use them, you definitely have to keep that in mind. So injection of cement after fixation, the cements are injected in two places, either in the metaphyseal, the head neck junction areas, or at the tips. I think people have used it in two different ways, and various evidence has shown how it works. Okay. Few papers available on cement, and this is currently being studied extensively. Definitely secondary displacement rates with the use of augmentation with cement, especially the tip, are lower. Somehow the higher AVN rates were shown in the studies, but I think maybe there was more 3 and 4 part fractures. But and then definitely try to avoid cement injection when there is suspected head split. So I think penetration of cement into the joint is a big no, and this must be avoided. So I think you also need to check that your screws are not intra-articular before you inject cement. That's again mandatory. But this is helpful in very patients with low BMDs or very elderly patients where you think that this head can be preserved, and the hold is not. So I think this is again an on-table decision that, or a pre-operative planning decision that you need to be taken. Okay. Which are the screws that are preferred? And then if you see your Philos plate, then I think it's more often than not the A and the B screws that very often are used for augmenting, followed by the E screws. Very interesting trial, which was a multi-center randomized trial, which the main objective studied was of risk of failure at 1 year. This trial somehow, found the initial studies were there not big statistical difference in function, but somehow this trial was prematurely terminated because they thought that the numbers were not enough, and some of the patients also fell out of the studies. And the conclusion of this large multi-center trial was that they need meager numbers. So I think this is something that's an evolving evidence. So we still don't know. Plus, I think if you see commercially, I think the cement injection is still not being pushed or marketed so aggressively yet around in companies that make it or use it. So I think this is something that we need to be watch about. Okay. That comes down to fibula, and fibula, most of us are familiar. We have used fibula in very other different situations. Use of fibula, especially when it is definitely shown that the bone stock or the strength of the construct is almost 200% this is one good paper from Lee et al. And it is useful for preventing or supporting the medial calcar and preventing the loss of reduction. And the work of Gardner et al. in 2007 is an epic paper which supports the role of calcar reduction, restoration of calcar in the long-term outcome of proximal humerus fractures. What worries me for using the fibula is that you can't shove the fibula in easily. So I think to get the fibula in, you really have to then displace these fractures pretty well. So I think all the soft tissues around are probably gone around. But I think there will be some fractures where this will be helpful. Our challenges with fibula is that we don't get allograft fibula, and I think we would be definitely worried of using a fibula or taking out a fibula in a 75-year-old with the risk of morbidity involved with that. So if you have allograft, then this is easy. You have an additional armamentarium table, and you could use it in some situations. But I think if it has to be a live fibula, then you would probably be questioning your decision whether it's, the morbidity is worth the risk in a situation. Ideal length of fibula, don't put in a too big a fibula because it gets in the way. So in case you have failures, this big fibula will definitely, cause problems. 4 centimeters is ideal. Last 5-6 years, 4 big clinical studies have shown that no screw cutout because of, so it supports or it decreases the risk of screw cutout. However, if you have 3 and 4 part fractures, if you have osteonecrosis, then I think the arthroplasty surgeons probably won't like a big fibula down there for them to get the prosthesis on. So I think in 3 or 4 part fractures, I think the role of fibula, a lot of authors will question. Okay. Most recent paper, so I think it's the posterior medial calcar combination where surgeons might be thinking or contemplating the use of fibula. And I think this has shown that it will help. However, the current evidence is still not enough. Surgeons have tried plates or something similar to plates, like the concept of an under case from my colleague. So medial support to this. So if you want that this doesn't collapse, which is what you're doing with the use of fibula, then you need some support, either mechanical or with this thing. And this is what your aim of supporting is. Okay. So I think finally, if this is still an evolving science, I think the evidence or the current evidence does not show that the role of augmentation is fully understood. I think we have to consider costs and understand risk benefits of using this. There is still evolving evidence in this, but I think the final aim of fixing these fractures in elderly population whose incidence is definitely increasing is to make sure that you get good stability on table. You don't want to fix and then leave them alone. You want to get them going or moving. So I think the role for augmentation, if I conclude, will be there in some subset of patients where it's a surgeon's decision on table where you think that doing this will definitely add to getting this or moving these patients early out. And we need to get enough still evidence to show that this definitely helps, but it's definitely much promising that doing some things or few things, especially injecting cement, is a useful armamentarium in improving outcomes in proximal humeral fractures. Thank you.
Thank you very much, sir. There are many questions on YouTube. Since we are running a little bit late, we are going to take few questions directly, and a few questions will be answered on YouTube. So there's a question to Dr. Hassan. When to do the total shoulder arthroplasty and when to do an reverse shoulder arthroplasty? Dr. Mukhi is asking. Dr. Mukhi is a consultant practicing Mulund regarding choice of TSA versus RTSA.
Yeah, well, I think for a fracture, I wouldn't really do a total shoulder. I think the risk of if we're talking about an anatomic total shoulder with a glenoid component, I think the risk of failure of the polyethylene component would be too high, and the risk of instability would be too high. So I think you're much better off doing a reverse arthroplasty in that situation, or a hemiarthroplasty potentially. Again, hemiarthroplasty is not a bad operation. I would argue that hemiarthroplasty is one of the more challenging operations just to restore your anatomy correctly, and that's why it has such a mixed results. And that's why I think the reverse is more forgiving.
And another question, just to follow up the same trail, that I think you mentioned that results of RSA are not good if you do it after hemiarthroplasty. So particular reasons for that?
Well, it probably again relates to the tuberosity. So usually, if you're operating on a failed hemiarthroplasty, it's almost always because the tuberosity has failed, right? So the greater tuberosity has failed, it's pulled off, it's retracted, and so now you're in a situation where you don't have perhaps any posterior superior cuff to bring back to restore external rotation. So either either you leave it without anything, or you or have to do a latissimus transfer, which increases the complexity of the operation and the rehab. So whereas if you do a primary reverse, usually the tuberosity healing rates are significantly higher in a reverse arthroplasty than they are in a hemiarthroplasty, and that's probably for a variety of reasons, including the fact that you're more medialized with the reverse arthroplasty, and it takes the tension off the cuff.
There's another question from Dr. Maheshwari. He's asking about non-reverse option in the elderly displaced fractures. If we cannot do a reverse, what would you do?
Well, I guess your choices, of course, are to try and fix it, right? So you can, if it's fixable, you fix it, and if you can't, I'm not sure I quite understand the question, but if it's not fixable, and then you're left between the choices of doing a hemiarthroplasty or reverse arthroplasty, and I would argue if it comes down to those two choices, and you have the reverse available to you, then the reverse is a better choice. But if the reverse, for whatever reason, is not available, then hemiarthroplasty or doing a ORIF.
Okay, thank you. Should we move on?
Yeah, one more question. The role of the unique prosthesis, just unique prosthesis, wherein there is a intraosseous, basically a base plate that goes into the head and that is connected to the shaft. The particular company from France is marketing this prosthesis for the endoosseous, basically osteosynthesis.
I'm not sure. Dr. Hassan, are you aware of the just unique prosthesis?
I have no experience with that prosthesis. No.
Is it available in US? The just unique?
I have not seen it, and so I'm not sure. I can't say for 100% it's not available, but I have not seen it here.
So I think we can move on to the next session, and we have a lot of questions on YouTube, and that will be answered particularly directly on YouTube by all the faculties. So since we are getting late, I would request Dipit to go ahead with the second session.
Correct. I'll just share my screen. So we are moving on to the next session of clavicle fractures. I've made a list of recommended reading. I'll be sharing it on YouTube also. All the PDFs will be available, and this session will be on clavicle fractures. We have Dr. Kapil, who's from Wood End Hospitals in Aberdeen, and we have Dr. Hassan again speaking on lateral and clavicle, and Tanna sir will be speaking on how to salvage complications. So these are the recommended reading of clavicle fractures. I'll be sharing it in the YouTube, the link, and people can download the PDF. Can I ask Dr. Kapil from Aberdeen to upload or to share his screen? And his talk is on midshaft clavicle fractures, the eternal debate of decision making.
Thanks, Dipit. Can you hear me?
Yes. Clear.
And can you see my screen now?
Clear, yes. Please go on.
Right. Good morning. And thanks very much for the invitation to talk about a few things today. And it's been quite interesting listening to the various speakers in the first session. So I'll see if we can live up to the marks. Clavicle fractures. So my remit is to talk about the midshaft. But if you look at the overall incidence of clavicle fractures, there is a very high incidence in the young men. And you can see the blue line here is the male line. And again, in the younger age group, it's a very high incidence of young active men. So, and if you look at the overall incidence, it counts for about 2.6% of all fractures. in the body. And for classification purposes, which we're going to look at in a second, there is a number of classification systems, but they essentially divide the clavicle into fifths. So you've got the medial 1/5, the middle 3/5, and the outer 1/5. And we all grew up reading the Allman classification, where the middle third was the type 1s, the lateral third was the type 2s, and the medial third was the group 3s. But Mike Robinson, who works not a million miles from where I am, introduced this classification, the Edinburgh classification, in a paper in 1998. We sort of went from type 1s, which are medial, to type 2 in the middle, and type 3 in the lateral. So essentially this morning, we're going to talk about the Edinburgh type 2s or the Allman type 1 fractures, which account for the vast majority of clavicle fractures. So why are we talking about these? These are very common injuries. We all know what to do with them. But as Dipit said, it is the decision making. So what I'm going to try and focus on is, how do we treat most of these fractures? What are the issues with treating them non-operatively or operatively? And then when you fix them, what are the particular challenges, but how do you come to a decision what you're going to use to fix them and which ones to fix? So in all decision making, the first thing starts with the patient in front of you. It's not the X-ray, it's the patient we're treating here. So what was the mechanism of injury? Was it a low energy injury? Was it a high energy injury? What are the associated injuries? Again, they are an important part of your decision making. Who is the patient in front of you? Have you got a young 25-year-old active man, or you've got an elderly patient with low demand and maybe not fit for surgery? What is the soft tissues around where you are working? If you look at this picture, this clavicle is just threatening to poke out of the skin, imminent. It's imminent puncture of the skin. So it is an indication where you will be swayed towards operative fixation because the skin may be compromised. Is it an open or a closed injury? And what are the associated neurovascular injuries? So that's a part of your initial judgment, assessment, before you make any decisions about how you're going to treat these fractures. Then the other dilemma or decision making is, if you're going to treat it non-operatively, how do you treat it? And when I was training in India, we used to put all of these clavicle fractures into a figure of 8 bandage. And it must have been pretty uncomfortable for patients, because we used to call them, and this is of course going back more than 30 years, they used to call back every week to tighten this bandage. It must have been pretty uncomfortable. And when I moved to the UK, I never saw a figure of 8 bandage. Everyone was treated in a sling. And if you look at the literature, there is no evidence that putting the patient into a figure of 8 bandage improves the chances of union or improves the position in which the fracture heals. So a simple sling is enough to treat these fractures non-operatively, and there's no need for a figure of 8 bandage. So what are the problems with non-operative treatment? We know that the vast majority of these will heal with a non-operative treatment. But the biggest risk factor, or the biggest complication of non-operative treatment, is non-union. And the literature will tell you that there is a non-union rate of about 15 to 25%. And we are all led to believe that most of these fractures will heal, even if they heal with a degree of shortening, there is no problems. But if you look at long-term outcomes following clavicle fractures, so at 10 years, nearly half of the patients had ongoing symptoms, while only 15% were ununited. So even if the fractures have healed with a degree of shortening, there is some degree of shoulder dysfunction. Mike McKee's study from Canada looked at strength deficits at 4 years post-fracture, and they found that the significant number of patients had some strength deficit in their upper limb and shoulder girdle at 4 years after their injury. But a subsequent paper from Edinburgh refuted that, and at 12 months, they did not find any association between shortening and functional outcomes or patient satisfaction. So the literature is divided. And what's been my personal experience? There are a very small number of patients do complain of ongoing shoulder discomfort and dysfunction, and probably because of the altered mechanics, because of significant clavicle shortening. The other issue is the cosmesis. And yes, vast majority of clavicles will heal with a degree of shortening and a bump. But if you look at, again, this is data from Mike McKee's studies, and patients do have an issue with a droopy shoulder or an asymmetry in their shoulder appearance, which is very significant that they're not so much worried about the scar. It's only 3 out of 62 patients were worried about the scar, while 22 out of 49 patients were worried about the bump or the asymmetry, and the statistically significant differences in what they felt or perceived about their shoulder. So again, that's a factor that you have to consider, or when you counsel your patient in your decision making. Non-union, as I said, is a very common complication of non-operative treatment. This is one of my patients, and this was the injury occurred in 2010. Yes, I think it was reasonable to treat her non-operatively. This was a CT scan in 2014 when she still had an established non-union, and we finally fixed it in 2017 to take this non-union apart and fix and bone graft it. So what does the literature tell us about who to fix and when to fix? I think this was a paper, a landmark paper, which swayed us all towards fixing most of these displaced clavicle fractures. Is a multi-center trial from Canada, published by Mike McKee in 2007. And their conclusion essentially was that they supported primary plate fixation of completely displaced midshaft clavicle fractures in the young adults. And that was probably which we all latched onto, and we started fixing a lot of these clavicle fractures. But then subsequently, Mike Robinson from Edinburgh challenged this, and he did a Scottish multi-center trial and came to slightly different conclusions. But if you look at the paper and you read, go away from the headlines, what he said was that if you took away the non-unions, which skew your overall functional results, then the patients did equally well, whether their fracture was treated operatively or non-operatively. Essentially, if they healed, their functional outcome was fine at 12 months, unlike what Mike McKee's issues were with droopy shoulders or weakness in the shoulders, etc. And a subsequent paper from the same group has looked at cost analysis and felt that routine fixation of displaced midshaft clavicle fractures is not cost effective. So who do we fix? When do we fix? And I think this is a nice sort of checklist. You know, if you've got significant displacement of more than 2 centimeters, which essentially means that the fracture is shortened by more than 2 centimeters, or you've got significant comminution, and of course, open fractures and other associated injuries, which will force you towards fixation. But for me, significant shortening and overlap in a young adult, especially if it's a dominant arm, will lead me to sway towards fixing the fracture rather than non-operative fixation. And so that is where we come to. These two fractures are different. This fracture is likely to heal. They are in a similar location, but you can see that there is a displacement of the fracture in this X-ray is significant as compared to this one. So I'm sure most of us would agree that we will try and we will be probably swayed towards fixing this fracture, which is significantly displaced, while a similar fracture will probably be best treated non-operatively. So the next dilemma is, if you've decided to fix it, what are you going to use? Are you going to use a plate, or are you going to use one of these intramedullary devices? Again, a plate is something that we've all grown up with, but however, it is more invasive. And invasive in the terms of not only a dissection and exposure to the fracture site, but also once you put the plate on, there is issues with prominent metalwork and need for further metal removal. But I still think that a plate gives you the most stable construct to deal with these fractures. Personally, I have no experience of using an intramedullary device, and it'd be interesting to hear from others in the faculty or even the audience if you have got experience of the intramedullary devices. But whatever intramedullary device you use, there is the risk, or there is the issue with rotational stability and whether you can mobilize these fractures soon after fixation with an intramedullary device. However, it is minimally invasive and causes less cosmetic concerns. The next thing is, when you plate it, where are you going to put your plate on? Are you going to put a plate on the superior aspect of the clavicle or in front? And again, the issues with both of these sites for plate fixation are specific, and we can look at that. The anterosuperior is mechanically stronger. It controls the deforming forces better, but you've got a smaller superior inferior dimension of the clavicle. Hence, you are not able to use as long screws as you would be able to do in an anteroinferior plate position. And you've got the risk of injuring the pleura or the neurovascular structures on the inferior aspect of the clavicle with a superior plate position. And of course, the prominence of the plate is less if you put the plate in an anteroinferior position. Again, my personal preference is to use the plate in an anterosuperior position. And yes, I've had one pleural problem, and that was in the patient that I showed you the X-rays of the non-union, and that was one pneumothorax that I've had in all these years of fixing clavicle fractures. So what are the, if you look at the literature, what are the recommendations for treatment of these fractures? Probably young, active patients with completely displaced midshaft clavicle fractures, best treated with fixation. Anteroinferior plating does reduce the risk of symptomatic hardware, but again, probably the superior plate position is stronger. There are complications that I'm not going to dwell deeply into this because the issues are about decision making, but you have to be aware of these complications when you're counseling your patient. As I said, most of the issues can be infection or hypertrophic scars, but neurovascular injury and pleural injury is something that you have to be aware of. And since that patient had pneumothorax, I now put it on my consent form, pneumothorax as one of the recognized complications of the fracture. And a significant number of, and you may have to remove the plate because of its prominence. And this is an old X-ray with a DCP plate, which obviously caused more problems with prominent metalwork. But now the availability of pre-contoured plates makes, these are low profile, and you may not have to have similar problems with prominent metalwork as compared to the previously used DCP plates. So in summary, clavicle fractures are common in midshaft. And although you can treat most of these with simple immobilization, but shortening, non-union, and malunion are the concerns, and that is what you have to discuss with your patient. So personally, I would, if I had a young 25-year-old man sitting in front of me with a displaced fracture, I will tell them that yes, most of these will heal, but there is about 15 to 20% chance, 1 in 5 chance that it may not heal and you may need further surgery. A very practical decision-making thing is that if, in my experience, if your patient is still in a lot of pain at about 6 weeks, then it's most likely that fracture will not heal and you should maybe jump onto fixation at that stage. And of course, you have to make your patients aware of all the risks and complications, including infection, prominent hardware, neurovascular problems, pleural injury, etc. Thanks very much.
Thank you, Dr. Kapil. We'll move on to Dr. Hassan's talk on lateral and clavicle now. Dr. Hassan, can you share your screen and unmute yourself?
Yeah, sure. Let me just give me a second here.
We'll just request every faculty to limit the talks to 10 minutes because we are overrunning our time.
All right, Dipit, can you all see that?
Yes, clear.
You can hear me okay? All
Yes,
right, great.
Thanks.
Okay, so my charge is distal clavicle fractures. So these are comprise a minority of clavicle fractures, about 15 to 30%. However, they make up a significant percentage of the clavicular non-unions. And this is, certainly due to the mechanics around that fracture, where you got the pull of the trapezius on the proximal fragment, and the distal fragment is being displaced inferiorly from the weight of the arm itself. More males more than females, and typically in a younger age group, but certainly can be seen across the spectrum of the age spectrum. The classification, so Rockwood modified the neo classification, and really the ones that are of biggest concern are the type 2 fractures, specifically the type 2A and the type 2B. which both can result in significant instability of the medial fragment. And those are the ones that we're going to sort of focus on. Cho introduced a new classification, which I like this classification. I think it breaks them down basically into type 1 and type 2. Type 1 is stable, type 2 is unstable. And then 2A and 2B are basically the same. 2C though is an addition, and I think it's clinically relevant because you do see these where you have this very small lateral fragment, and that could affect your choice of treatment. So natural history. So what we know is that asymptomatic non-unions are very common. In multiple studies in literature supporting this, study of Nordquist in 1993, they had a 15-year follow-up on 110 fractures of the lateral clavicle, and of which they had 10 non-unions and 8 were asymptomatic. And so their conclusion was that they conclude that fracture lateral of the clavicle does not require surgery. And this was a study of Robinson's out of England, or maybe Scotland, I guess, with 101 distal clavicle fractures. Average constant score for all comers was 93. They did have 32 non-unions, so again, falling into that category around 30% non-union. Interestingly enough, though, there was no difference in average constant score between healed fractures and non-unions. In other non-unions, 21 were asymptomatic, 11 underwent a delayed surgical intervention. So again, additional evidence supporting that a lot of these can be treated non-operatively. So if you go down the non-operative route, very similar to the talk we just heard, a sling for comfort, and start mobilizing them at 2 weeks. Risk factors for non-union, certainly 100% displacement, no cortical contact, and advancing age. Both have been shown to have an increased risk of non-union. And in terms of deciding, whether you're going to fix this or not, again, that really depends on patient factors. Younger, perhaps more active patients would be ones you would potentially also take into consideration along the degree of displacement. The multiple operative options have been described. A pre-contoured locking plate with or without CC fixation, hook plate, CC fixation by itself, transacromial wire fixation plus or minus a tension band. You do have to worry about wire migration, so that's not really used as often anymore. Certainly arthroscopic techniques have been recently reported. High union rates have been reported basically for all of these techniques, regardless of technique. But there is also a high complication rate. So lock plating, example of this, where you have a reasonable sized lateral fragment. I would argue that this is one that you could consider treating non-op actually. This did undergo primary lock plating without any corticoclavicular fixation. So a couple of different studies in the literature on this. Study by Shin et al. They did they had 25 lock plating without CC fixation. They had 100% healing rate. They did notice an increase in the corticoclavicular distance compared with the contralateral side when they looked at post-op films, but there was no difference in the outcome if the distance was greater than 10% compared to the contralateral side versus less than 10%. So in other words, the fracture's healed. There was some increase in the CCD, but clinically that made no difference. Hook plate is another option. The thought process behind this plate, of course, that it's quick, it's easy, it's very powerful in overcoming the force of trapezius. It does allow you to bypass potentially poor bone and lateral fragment. You really don't even have to get anatomic reduction. You can sort of put this plate down, get the bone reasonably well approximated. And it's likely going to heal. But it also has, and just an example of a hook plate, a small lateral fragment. But this has got significant disadvantages, right? It requires a second surgery to remove. You cannot leave this in. And it's been associated with complications, including cuff impingement, tear, stiffness in a significant portion of patients, which may require an arthroscopic release at time of the plate removal. So additional surgery, if you will, just to treat the side effects of the plate, subacromial osteolysis, erosion fracture, and clavicle fracture immediately the plate has been described. Arthroscopic techniques, the advantage of this is minimally invasive. You can address any concurrent interarticular pathology, which, if you look at some, I think you have to be careful with that because you don't know what is really degenerative changes versus non. So that's a little bit of a slippery slope. Disadvantage of the arthroscopic technique is it's technically demanding. There's a learning curve. There's clearly some increased time when you're first starting to do this. And given that they're suspensory, it's all basically suspensory techniques, it raises the specter of coracoid complications. So this is one of the arthroscopic techniques, where you basically, and there are various ways of doing this, right? You can do with a single suspension, a double suspension. So there's a variety of ways of doing this, or even with allograft augmentation, arthroscopically assisted. This is an open technique where you reconstruct the CC ligaments and then do a additional suspension for initial static constraint. And this group out of Miami reported on 22 patients with no non-unions. They did not, however, report their CC measurements post-op. But again, we talked about the complications. Complications are high in this fracture. In fixing this, there's about a 30% complication rate. Hook plates significantly increase the risk of complications, which is why I think there's been a move away from hook plates for this injury. But even lock plates can sometimes require harder removal. So, we know that the natural history also, after surgery, there's multiple studies that have demonstrated no difference in outcome scores between those treated operatively versus those treated non-operatively. And that's in multiple different studies. So, the way I approach these, most of these I treat non-op. There's no high level evidence supporting operative intervention on a routine basis. I think it's important to discuss with the patients that if you're considering surgery, that outcomes are similar between operative and non-operative intervention. And surgical indication, of course, you want to take into account the stability of the fracture, size of distal fragment, and also the patient demands and patient age, in deciding whether or not to proceed with surgery. I will typically, if I'm fixing these, and like I said, I don't fix these very often, but if I do fix them, I'm typically using a pre-contoured locking plate. I don't use a hook plate. I think I don't want to go back a second time and take that plate out, and I don't really want to. I don't want the potential complications. And the patient population in Baltimore, sometimes we don't get great follow-up on some of our patients from the trauma site patients, and so they're walking around with this hook plate in for a year or two. I try and avoid CC fixation. I just don't want to introduce potential iatrogenic issues from involving the coracoid. And we know that biomechanically there's been multiple studies done biomechanically of lock plate with and without CC fixation. As biomechanically, there's no difference. Clinically, you can see interval increase in the CC interval, CC distance. But that's also been shown to be not clinically relevant. So it's just really an X-ray finding. If the lateral fragment is too small or osteopenic, the CHO type 2C, I think those you can make it. That's make a good argument for so-called benign neglect. And if you need to, you could go back at a later date and potentially do if it's symptomatic, and do a delayed surgery. If you're going to do something primarily, you could I would do an AC ligament reconstruction in that case, and avoid the hook plate. Thank you.
Thank you for that talk, Dr. Hassan. Very well. Can we move on to Dr. Kapil's talk? Can you share your screen?
Yeah, let me stop sharing here.
Thanks, Dibit. Can you see my screen now?
Yes, yes. Please go on.
Yeah. Thanks. I'm going to talk about acromioclavicular joint injuries, and I think there will be a bit of overlap with the last talk in terms of management. So if we just quick recap of the acromioclavicular joint, we know that it's a diarthroidal joint, but the ligaments that here are that of interest to us are the corticoclavicular ligaments, the conoid and the trapezoid ligaments, and the acromioclavicular ligaments. And we have to remember that there is a small intra-articular disc inside the AC joint, which can sometimes be responsible for ongoing symptoms after not too severe an AC joint injury. Ongoing pain in that area could come from a torn intra-articular disc. The corticoclavicular ligaments are important for superior inferior stability, while the AC ligaments give you anteroposterior stability. And that's what we have to think about when we are managing these injuries. We have to look at the instability in these two planes. And when we talk about the classification fixation, we'll talk a little bit more about this in a second. So how does the injuries occur? Most of these injuries occur due to direct force landing onto the point of the shoulder, where the force is transmitted into the acromion, pushing that down. And this is one of my patients who was snowboarding somewhere in the Alps and had a fall, and sent me this nice video. And if you see, he lands directly onto the point of his shoulder after his jump. And he came in with a significant AC joint dislocation. So the force is transmitted onto the acromion, pushing it down, and rather than the clavicle going up. The clavicle stays where it is, but it's the girdle that goes down. We're all familiar with classification by Rockwood, where type 1 is a sprain of the AC ligaments, and type 2, the AC ligaments are torn, but the CC ligaments are okay, so they're essentially stable. In type 3, you've got tearing of both the CC and the AC ligaments. And in type 4, the dislocation is posterior. In type 5, which is further along from type 3, there is further injury to the delta trapezial fascia and more significant displacement of the clavicle. And in type 6, there is an inferior displacement of the clavicle. Interestingly, more recently, there has been a consensus statement from Isakos, which has proposed that we should add or subdivide the type 3s into type 3A and type 3B. And what do they mean by that? They are then now looking at the instability in an AP direction. And I'm going to talk about that in the assessment of these patients in a second. So how do you make a diagnosis clinically? From the history, if the mechanism of injury fits, there may be a prominence of the distal clavicle in type 3, 4, 5, in the type 3s and 5s. Patient may complain of pain in this area, and there is localized tenderness. But I think the cross-arm adduction is quite an important test to do. So if you put your patient's arm across the body and the clavicle becomes more prominent, or there is more overlap, that shows you that there is instability at the joint in an AP direction rather than just in a superior to inferior direction. And that's what the 3A, 3B is, that if you do the cross-arm adduction and there is no significant prominence of the clavicle, it's a 3A injury. But if there is significant instability in an AP plane, then it's a 3B injury. Plane radiographs usually suffice to make a diagnosis. A Zanker view, which is where the X-ray beam is tilted CAFL at about 15 degrees, gives you a better profile of the acromioclavicular joint and can be used. I'm just going to talk briefly about the stress radiographs. And again, this is mentioned in the literature. A few years ago, it used to be very popular, where you will hang weights from the patient's arm to see if there was any further apparent displacement on an X-ray. But I really don't think that add any value to a diagnosis which is made clinically and on simple radiographs and causes discomfort to the patient. So in my practice, I've stopped using it. And if you look through the literature, again, there is no value in using a stress radiograph for AC joint injuries. So management, type 1s and 2s are usually treated non-operatively. You give them a sling for comfort for a few days and then early mobilization. But remember, up to about a third may have some long-term pain, which is probably due to invariably to the injury to the AC ligaments or the torn disc. And in that case, an ultrasound-guided steroid injection into the AC joint helps to relieve their symptoms. But if you don't have long-lasting relief of symptoms after an ultrasound-guided injection physiotherapy, you may be inclined to do an arthroscopic excision. Essentially, that's a debridement to take the torn disc out. It's the type 3s that are the most controversial area. And the literature will tell us that you can treat this non-operatively in most of the patients with the type 3 injury, and surgery if they have got ongoing symptoms with non-operative treatment. But there is no prospective randomized controlled trials to tell us exactly who to operate on, when to operate on, and what to do. But it's quite clear that 4, 5, and 6 types, you would consider surgery in most patients. And that is to achieve stability in both the planes, as I said, in a superior to inferior direction, but also in an AP direction. So you're restoring the corticoclavicular ligament complex, but at the same time, you have to repair the deltotrapezial fascia. You have to bring the clavicle forward because it usually goes posteriorly along with going superiorly, and you have to stabilize in both the planes. So how can you achieve this? In an acute situation, as we heard in the talk on distal clavicle, you can reduce the AC joint and use a corticoclavicular device to approximate the ligaments and thereby encouraging primary healing of both the CC and the AC ligaments. I don't think there is a role for any autograft augmentation in an acute case, because if you get them early, you're able to bring the ligaments together and they should heal in that position. And you can achieve this either arthroscopically or open, and I'll tell you what do I do in a second. So you can use one of these commercially available jigs, and you can do a corticoclavicular fixation using dog bone or tightrope techniques. But you have to remember that you have to control the deformity in both the planes, which is superior to inferior and anterior to posterior. I prefer to do it open. So in the type 5s, I would prefer to do an open repair. And I think the advantage is that you can accurately reduce the acromioclavicular joint. You can debride the torn disc in the AC joint. But most importantly, you can repair the deltotrapezial fascia and also the AC ligaments. And that gives you stability in both the planes. I think one of the advantages of arthroscopic technique is that you've got very good visualization of the undersurface of the coracoid, and passing your tunnel in the coracoid is the key. And of course, you don't disrupt the deltoid attachment. Personally, I don't think that that's a big problem, because you can work on the base of the coracoid through the deltopectoral interval and you don't detach the deltoid. And on the top, you can make a longitudinal incision over the deltotrapezial fascia and repair it later on. The other little technical tip that I would give you if you're doing an acute repair of the AC joint is that when you make a drill hole in the clavicle to pass a CC device, make it a little bit posterior, and then when you pass the CC device, it pulls the clavicle forwards towards the coracoid and giving you that restoration of the anteroposterior stability as well. As I said, you can use an AC joint tightrope, but I think biomechanically a dog bone device, which I use now, is better. And also with a dog bone device, the drill holes in the coracoid are smaller rather than as compared to the tightrope device. I'm going to skip this video. So then you come to the chronic AC joint dislocations. So who do you operate on? Now, this is probably a type 5, and maybe we should have dealt with it acutely. But in the chronic situation, what do you do? Do you just do a mechanical stabilization? Do you do a mechanical and biology? And what do you use for biology? Pure mechanical devices for chronic reconstructions, I think, have got some problems in terms of long-term failure. We know that any synthetic device will undergo fatigue and failure over the long term. And there's a number of them available in the market. In the UK, we've got the large ligament, which has got two drill holes in the clavicle, trying to recreate the corner of the trapezoid, and the lockdown device. Essentially, they're all very strong synthetic braided polyester or some version of it. But relying purely on a mechanical device, in my experience, has not been very fruitful, and you have to add some biology to it. So this was a patient who had a tightrope fixation, and this was done by another surgeon. I don't know what this anchor was serving the purpose. And then 3 months later, it did fail. I attempted a lockdown reconstruction, but again, which seemed good at the time, but it failed. And then we had to rely using a hook plate in the final analysis. We did hear just briefly about issues with hook plate. And yes, you have to remove them about 3 months' time, but this one was left for a few years, and the hook broke off, and we had to go and retrieve the hook. But it allowed me to do an arthroscopy of the shoulder as well. And interestingly, the rotator cuff did not show any significant damage, but we had to do residual reconstruction to augment the AC joint stability with a hamstring graft to restore the function and stability. So if you're doing a ligament reconstruction in a chronic situation, what are your options? The classic has been the Weaver Dunn reconstruction, where you transfer the coracoacromial ligament from the acromion to the distal clavicle, restoring the CC ligaments, such like. Or you can reconstruct the CC ligament with an autograft. And this is what I prefer to use. So as you can see, I've opened the base of the coracoid through the through the delta pectoral approach. I use a semitendinosus graft, and which I then use as a figure of 8. So from the medial side, I go behind the clavicle and pull the clavicle forwards, and then suture the graft onto each other over the top of the clavicle, and secondarily stabilize with a dog bone device. The advantage is that it restores not only the stability in a inferior to superior direction, but also provides me with AP stability. So this was a young lad, who had a reconstruction of his acromioclavicular joint done, and this is a year afterwards. As you see, I've done it open, but got good functional restoration about a year after his surgery. This is another one. This chap came to see us after the lockdown. He had this injury and came about 3 months later. Now that 3 months is a bit of a, for me, whether to a chronic, treated as a chronic injury or as a fresh injury, but I decided to fix him with an autograft semitendinous autograft and a dog bone device, and achieve reasonably good stability of the AC joint. Just to bring to where we are in the UK, this is a survey from a few years ago, and this was a survey of the members of British Elbow and Shoulder Society, and all the responders would treat type 3 injuries conservatively initially, and most of the operations were done about 3 months after the initial injury, so they were being done as chronic reconstructions rather than primary fixations of AC joint. And this ties in with the ISAKOS consensus statement that was published recently. And they would say that in the type 3 injuries, you would do a non-surgical treatment initially, but you have to have a discussion with your patient. You have to, there are times when your patient is a high demand athlete or a high demand professional who needs to get back to work quickly and cannot wait for 3 months to make a decision. In that case, you would consider surgical fixation at about 3 to 6 weeks time. But in type 4, 5, and 6, you would consider surgical treatment primarily. So my practice is that in
Dr.
type
Kapil,
4, 5, or 6, stabilization using a dog bone device is an open one. And in type 3, I would treat them mostly with non-operatively. Thank you.
Thank you. Thank you, Dr. Kapil. We'll quickly move on to Dr. Tanna sir's talk. We have 11 minutes left. Tanna sir, can you share your screen and start your talk?
My talk is how to salvage complications of conservative and operative treatment of the clavicle. This is what's for a long time. Till the new evidence came, not needed, and it has been mentioned very well by Dr. Kapilna that nowadays this is what is being done. This was standard treatment if the patient was fortunate to refuse an operative treatment for the fresh fracture. Because only time we operated clavicle was a non-union. Otherwise, we didn't operate clavicle for a long time. And this is a 3-year non-union. And this is the one other patient which we operate and becomes all right. But I'm coming to this a little later. Then the commerce took over. And we added one more fracture for a surgical treatment in fresh fracture. It was done methodically by creating an evidence first. Then the evo came out with the clavicle plate. And hamara log ka takdir khul gaya. Created evidence why fixation of the fresh fracture, clavicle and no conservative treatment. It has been very well mentioned by Dr. Kapil Kumar. Long-term results of grossly displaced fractures were not that satisfactory. And it is a debatable. They all improve, gross deformity remains. That is also debatable. Though the deformity itself is not important, that is very important. Higher non-union rate, 15%. I'm not sure that is right, because I don't think it is such a high non-union rate. Even if it is united with the malposition, function is compromised in the strength activity due to the shortening of the shoulder blade. This is how it was said. And it is how it was proposed that if there is a shortening and if there is going to be these situations, then the function will be affected, even though united. And this is how it was quoted, that the shoulder length from clavicle, from the shoulder to the mid-sternum is reduced compared to this, and this gives rise to the functional problem. I'm not sure about it. And we started doing a primary plating in a 30-year-old, and we did this since this provided us a good plate. And a simple fracture, we cured him by this complex surgery. If he had escaped our clutches, he would have been okay without any treatment also. So now one reason to have a complication of a clavicle fracture is the primary surgery. Recon plate, we started initially inferior to the thicker plate. The reason to operate now is the second time, because we use this plate, it has gone into non-union, so we go back again and put in another plate. This is another one we operated upon primarily with this plate and it broke down. So another situation, we created the problem. If we had not done it, probably the fracture would have healed up. So we created a non-union and now we treated it. This was so with the literature up to date, I put a thick locking plate and this is started working very well. But then you can see what happens. You can see, count each and every hole. This is the complication we started in the clavicle fracture. And all these are the scars. Not all the time, but you can also get such an ugly scar at times. So the plate position, now the supraclavicular nerves, there are 6 nerves like this. I have never been able to demonstrate all 6 of them intact at the end of an operation. This is the 2 ways remain intact. As you can see, area of permanent numbness occurs. This were the 6. This is I started off 2 initially, that about 4 of them I could deal with, but at the end of the plate, I could have only 2 of them. So these are the nerves. We accept it that you will have some problem there. So in primary, we did this and see what happens. After in the treated, we created a non-union. Probably, I'm sure this would have become perfectly all right if in case we had not operated upon. And most of the non-union conserved are not really painful. Very few of them need the surgery. Particularly in a slightly person who is working not a hard work with their hand, they do not need surgery all the time. And here it is, it got infected. So this is the problem created again by the surgery of a clavicle fracture done primarily. And this was some of those enterprising surgeons started doing this X6 of this situation. It's not my idea, but it is not my case also, but this is how I've seen. So the people went on and on doing this primary surgery. And so chua maar ke billi haj pe chali. This is how it happened to me. So I almost given up surgery for the fresh fracture of the clavicle. Non-union, I do it. Fresh fracture, you don't need any damn thing to be done. It will just heal up like that without any trouble. Small bump will be there, which in a majority of the athletes also, it doesn't create any problem. Here was the fracture, bad fracture, which was advised surgery. And I treated in a sling, nothing happened. The fracture healed up 2 months and everything is perfectly all right. And you can see everything is perfectly okay. You don't need anything. Here was the fracture, advised surgery. Surgery is done and it breaks down. So now you need another surgery. So this is the surgery you needed. So this is what we removed the plate first, and we wanted to see whether there is any infection and all. And having this, we did the second surgery, put in the bone graft, and the things heal up. So this is the one surgery. The incidence of surgery for a clavicle increased as the primary surgery for the clavicle went on increasing. And you can see this is conservatively treated patient. This is just after the lockdown. This has become perfectly all right. Now here it is, the thick plate which has been used for the fracture. This is the non-union which is there, which you can easily treat them. This is the pakka non-union. You can start with the thick plate and the bone graft in between. But the main purpose of the whole surgery in this non-union of the clavicle is to really decorticate. And this is what it was. This was a non-union operated upon. This was operated upon and the whole problem came in. And that is the reason why we had to operate again. So I feel these are the clavicles which were otherwise didn't give much problem. The surgery itself started giving the problem. And here it is. I think my video is not working. This is the one, decortication. Once you have to do the thing, unless it is decorticated, it will never be able to do the thing there. To do the shingling, this is the shingling. I don't know whether this will work. No, it's not working. The shingling is the main part of a non-union. Unless and until the bone with the periosteum and the soft tissue involved, you got to decorticate this part, both proximally and distally. Unless you decorticate this part, this fracture is not going to unite. So the first and the foremost is the shingling, which you do it, open up the medullary cavity, and once having opened up the medullary cavity, it becomes much easier, and you put in the plate and the graft, and the fracture heals up without any major problem. So the treatment of the non-union for any bone is this shingling, which I feel is a major part. And then you put in the bone, because it is the bone unless and until the soft tissues are there, the fracture doesn't heal up. And when you're putting the screws, drill one cortex after giving, readjust the drill length to avoid a soft tissue on the other side. So you put in a sleeve. You put in a sleeve and allow it to go only the opposite side. And then on the Jacob's chuck, so you'll be able to drill it and not injure on the opposite side. These are the only few points which you got to do it intraoperatively when you're doing the non-union. In conclusion, today the reasons for operating on a clavicle fracture have reduced for me, because I do not operate primarily except in few circumstances. Indication of surgery on the clavicle fracture to me today is open fracture, neurovascular complication, floating shoulder, and a painful malunion or non-union or the spike of the bone, which is underneath. And here it is. This is the typical floating shoulder with the clavicle fracture. Now here is the intramedullary wire which I put in. This has been devised by Dr. Garigude, which is the screw fixation over here, which does a beautiful fixation. And if at all I do this intramedullary fixation, this is the type of a fixation I do intramedullary. And this is the one only when there is a hanging shoulder which you do it. Otherwise, most of the clavicles I do not operate these days, because I feel that they do not need it and it creates more problems than it solves. So in Germany, there is no punishment for a prisoner who tries to escape from a jail because it is the basic human instinct to be free. Same thing, if the surgeon decides to operate on a fresh clavicle fracture, it's not a crime. It is our basic instinct to operate, and so we go on operating. Thank you very much, friends.
Thank you, sir, for an excellent talk. I think we'll take 4 or 5 questions now. Can we put it to Dr. Kapil and Dr. Hassan and Tanna sir? What about the stress fractures after CP reconstruction? Mukhi sir is asking this. Dr. Kapil and Dr. Hassan, Tanna sir, can you unmute yourself?
I was just answering that on the chat. So for the stress fractures, my few tips would be: one, make sure that your drill hole that you make you don't do multiple drill holes for the clavicle. Make sure you've got sufficient distance between the lateral end of the clavicle and where you make your drill hole. Make sure the drill hole is more or less in the center of the clavicle, but as I said, to go a little bit posterior so that you can pull the clavicle forwards. And if you're using any tendon graft to reconstruct the CC ligament in a chronic reconstruction, there are techniques where you can pass your tendon through the clavicle as an intraosseous fixation. I don't do that because I think that increases the risk of a stress fracture. That is why I go behind the clavicle and pull the clavicle forward with one of the limbs of the autograft and then tie it on top rather than using another anchor into the clavicle. So these are my suggestions that I would use to prevent a stress fracture of the clavicle.
Okay, Dr. Hassan, yeah. So this question, what about the anterior inferior plating of the clavicle? Does it have any disadvantage or advantage?
Well, so I typically do superior plating, and I think that's biomechanically that's been shown to have the to be the strongest. I think obviously with the superior plating you worry about wound issues and plate prominence. So my incision is very low. My incision is well below almost the inferior margin of the clavicle, and then raise a full thickness flap. So my incision, when it's healed, is nowhere near the plate, and the plate is covered by a layer of intact tissue, if you will. So my preference is to do superior plating, but make my incision low to avoid wound healing problems.
Got it. What about the stress fracture after clavicle plating removal? Tanna sir, what do you have to say about this?
In inferior plating, I've tried it out, and I find it that for occasional surgeon, it's not very easy thing to handle because you go down from there. So I think unless and until you have got the experience of doing the things more frequently, then it's a different thing. But if an occasional surgeon tries to pass it the inferior plate, he may find a little more difficulty than the superior or the anterior plate.
Right. Another next question is, what about stress fracture after removal of clavicle plating? How to avoid that, or what are your opinions?
I don't think that's a very common issue after removal of the plate, because this is basically a non-weight bearing bone. And that's the reason why I think, and the plate also, because it gives you a problem, you take it out. Otherwise, you don't take it out at all. And if you plate, you take it out, and I don't think the stress fracture, like in the inferior extremity, is any issue into fracture.
Yeah, I don't take the plate out. So I can't remember the last time I took a plate out. I don't think I've ever taken a plate out.
Right. When would you remove the hook plate though, Dr. Hassan?
Oh, the hook plate. Well, that's different. Yeah. I think the hook plate, when I have used in the past, I try and get it out by 3-4 months out, really. I think that you really just need it there while all the soft tissues heal around it, depending on if you're using it for, I think one of the indications it can be used if you're doing an AC joint reconstruction, you want to protect your repair, and sort of belts and suspenders, if you will, right? A belt and suspenders approach. But yeah, I think 3 to 4 months. I think, you leave it longer than that, then you're courting potential complications.
That's in case of fracture though. Dr. Kapil, what would you say? But if you're using, have you ever used a hook plate for AC dislocation?
I've used it very, very rarely. I think I started using it when it came out many years ago. So if I were doing it for an AC joint or any indication, I would take it out at 3 months.
Even for a dislocation?
Yeah.
Okay.
If statement,
Yep.
if I can ask the faculty, the hook
Yes.
plate, it came as a big thing, and probably nowadays, if it is possible to avoid, I think I would avoid the hook plate all the time. Would you all agree, or you feel it is still of use there?
I would totally agree with you. I would totally agree with you, Dr. Tanna. I think hook plate is, it's really, you have to be in significant duress to use a hook plate in my book. I would try and everything, and especially now for outer end clavicle or AC joint, the outer end clavicle with a very small clavicle fragment, you can use a lot of these plates which have got the facility to use a CC reconstruction as well. So I would avoid the hook plate definitely.
Yeah, I agree. I don't use the hook plate anymore at all, basically.
Any idea, Dr. Williams, Dr. Jeff Williams?
Dr. Jap, you'll have to unmute yourself.
Yes. Well, actually, I use hook plate for the very chronic cases where I combine it with an hamstring graft. The forces are so high. I've seen failures with the dog bone and even dog bone with a tendon. So sometimes I rely on the hook plate in chronic cases, type 5, severe instability.
Right. It has a biomechanical advantage.
Definitely, yes.
Right. Any other questions, Pradeep? Do you see any other questions on the chat, or we move on?
There's one more question. Dr. Kaka is asking, a dog bone implant with fiber type and double breasted to the acromion. Any inputs whether such construct can work?
Yeah. Can I just answer? I have answered that on the chat as well. Yeah. So I think what you're talking about is that once you've done a dog bone and you still have AP instability, I think, would you like to recreate that? I personally don't have experience that in that situation, as I mentioned in the chat as well. I would tend to use an internal brace. So that's again similar idea. You're putting fiber tape across. There are, you could use, if you were using a tendon reconstruction, then you could weave the same tendon through the clavicle into the acromion. And I know Schiebel from Berlin has got he's got a technique of doing an arthroscopic reconstruction using the same through the AC joint. But personally, I think the way I do it is that when you put your graft behind the clavicle and you pull it forwards with one limb of your hamstring graft, and you strategically put your dog bone device in the clavicle slightly posterior, you are able to control it. And more recently, I've not had an occasion where I've got residual AP instability. But if I was in that situation, rather than drilling tunnels through the acromion and risking further fracture there, I would use internal brace to augment that. I don't know what others' experiences.
Yeah, I'll use the tail of the graft that I've used to reconstruct the CC ligaments and basically whip stitch that tail, and then just do drill holes, not like a dog or anything, and pass the sutures through those drill holes in time on the lateral cortex of the acromion to reconstruct the AC ligaments, if you will. So use the tail of the graft to reconstruct the AC ligaments. I am curious. I know, Dr. Kumar, you mentioned that for your acute reconstructions, you typically use suspensory fixation. So now, is there? And I'd be curious to hear your and Dr. Willems as well. Is there any times during for an acute reconstruction, especially, for example, you're doing somebody typically would be higher demand? Is there a role in your hands for doing a allograft reconstruction of the ligaments acutely?
No, I think it depends on what you define as acute. For me, anything before 6 weeks, I would define as acute, and I would not use any graft reconstruction. I would just rely on my CC reconstruction. But as I said, I do them all open. So that gives me an opportunity to address the dentotrapezial fascia and breast and double breasted. So I'd spend a lot of time in that closure once I've done my CC reconstruction. That's why I don't do them arthroscopic, but it's quite interesting that in our unit, I use biology for all my chronic reconstructions, while one of my colleagues, he doesn't use biology, and he only uses a dog bone device with an internal brace for his chronic reconstruction. And anecdotally, we are just looking at the results, comparing the two groups. Anecdotally, there does not appear to be any significant functional differences in functional or clinical outcomes after these reconstructions. So the answer to your question in a long-winded way is that if I'm doing them acutely, I don't introduce any biology, but I carefully repair the deltotrapezial fascia and structures on top so that I've got that second, as you said, belts and braces to prevent that superior migration.
Right. That's been a lovely session. I thank all the presenters in the session, Dr. Kapil Kumar, Dr. Asan, Dr. Tanna, and Dr. Dipit for a fantastic session. We've had a lovely overview in both these sessions on proximal humerus fractures and in clavicle fractures. Before we go on to the next half of our master series, and that is on scapular fractures and chronic dislocations around the shoulder, which is not uncommonly seen in India, I would like to take a break for 5 minutes. Number one, to invite our WIROC secretary, Dr. Mandar Agashi, to say a few words about WIROC 2020, which is scheduled for the March as a physical conference. Mandar?
Thank you very much, sir, for this kind invitation. As we all know, Bombay Orthopedic Society is hoping and preparing for WIROC 2020 unlock, which is to be planned on 19th to 21st of March. As with the year 2020 ending and hoping that 2021 will bring good news, there is one more good news which we are bringing to you, which is WIROC 2020 unlock. We have had excellent response to our abstract submission side. We have more than 250 abstracts which we have received, which we have divided into podium presentations, interesting case discussions, presenting your publication, video techniques, innovative cases. And we are hoping for an even better response for the registrations. The registrations, as you all know, are open. We are going to take all the precautions, all the health advisories really, really seriously. It's going to be an extremely safe conference. We are keeping it at Renaissance Convention Center, and the residential packages are something which are almost unheard of. It's only about 15,300 till about Jan 15th. We want all of you to come there, meet, greet, and discuss a lot of things orthopedics, not across the screen, but physically. We also have got very good non-residential packages. And from the academic side, with the advent of great digital technology for the web conferences, we are planning to have excellent virtual faculty from all over the world for our symposia as well as the main conferences. So we want you there. Remember the dates, 19th, 21st March 2021, Renaissance Convention Center. Kindly do come. Thank you so much. Sir, yes.
Thank you very much, Mandar. I personally am looking forward to this meeting with a lot of excitement, and I'm sure it's going to be a fantastic educational academic activity. And I encourage as many of people who are watching today to register for the meeting and take advantage of the lovely packages. I would also now like to invite Dr. Swapnil Kenny, our secretary, to talk about some of the other activities of Bombay Orthopedic Society which are going on.
Right. Welcome to this master series, all members of the Bombay Orthopedic Society. I wish you a very happy new year for the year 2021. Though all of us are now used to living in the COVID pandemic of COVID-19 in 2021, other than the physical activity, which is WIROC, which we have planned for this year, since we are hopeful that things will change and the restrictions would be on us, we have also planned a plethora of electronic activities for all of you. Other than the flagship events, which are the master series, which is going on right now, and the clinical meetings, which happen on every first Sunday of the alternate month, that is the even month, we also have a plethora of academic online courses for all of you all. Starting with advanced arthroplasty course, which is happening next week, wherein we have world-class faculty like Dr. Javed Parwazi, Dr. Farez Ha, Dr. Martin Potter, and Dr. Hemant Pandit, in addition to other faculty all across the world. The pediatric orthopedic course, the advanced pediatric orthopedic course, the foot and ankle course, the orthopedic oncology course, the technology skill course, and the pelviacetabular course. All these courses are online now from the Bombay Orthopedic Society. You can register for these courses and take advantage of these courses and the MMC accreditation points which come along with these courses from the security of your house. So I'm looking forward to all these activities and all the members taking advantage of it. Thank you very much, Dr. Zaveri.
Thank you, Swapnil. As you heard from our dynamic secretary, Bombay Orthopedic Society and its executive committee have not been sleeping over COVID. We have been active and we have done a lot of work over the period of COVID to continue academic activities for our participants, for our members, and for others who are interested in following our activities. Besides YROC, which is expected in March, as you heard from Swapnil, there are a host of courses online, and the response we have received for these courses is enormous. The basic spine course, which normally we get about 25 to, we accept only about 25 to 30 participants. This year we were able to entertain about 125 participants who were extremely happy about the program. Similar such programs were held throughout the year and will continue to be held in the next few months. So I encourage you to visit our Bombay Orthopedic Society website and get all the information on all these programs. Also, remember, Bombay Orthopedic Society is now coming up with a newsletter regularly, which will be of interest to you. We also have our video journal, which is excellent, and it's a review of interesting paper presentations on a particular topic, which is released every month. And I encourage all of you to listen to those and get hold of those also. It is very good. The Master Series, we finished 4. All of them have been seen by more than about 3,500 participants. And we have this one today. And the next one, which will come after 2 months, is going to be on injuries around the foot and ankle. So we are going to discuss calcaneal fractures, talar fractures, midfoot injuries, and open injuries around the ankle and foot area. So please keep abreast with BSS activities. Follow us on our website, follow us on our Facebook and YouTube channels, and you will be abreast with all our activities. Now, without much ado, let us move forward with what is the main program for the day and hand the mic back to Pradeep Nemade to take us to the next session. Thank you, Pradeep.
Thank you, sir. So we move on to our the third session, that is the management of the scapular girdle fractures. And now we have 4 talks in this. Dr. Jaap Williams from Netherlands, Amsterdam, Netherlands, is going to speak to us on why he conserves scapular fractures. And Dr. Dipit Sahu, consultant orthopedic surgeon at Cooper Hospital, is going to speak to us why he has a low threshold for surgery for scapular fractures. Again, for glenoid fracture, we again will have Dr. Jaap Williams to take us through the management principles of glenoid fracture. And in the end, Dr. Ashfaq Hassan again, he will guide us through the nuances of different approaches for the scapular fractures. So without further delay, I invite Dr. Jaap Williams to take us through the management of scapular fracture, why he conserves them. Over to you, Dr. Jaap Williams.
Thank you very much. Can you see me and hear me?
Yes, very clearly, sir.
Okay, thank you very much, Pradeep and Deepit. Talking about scapular fractures, conservative or operative, I don't think there is absolutely all conservative and all operative, so I'll put it a little bit in perspective. But first of all, let me go. I wish you a very healthy, happy new year without COVID, hopefully, and hopefully we can meet each other again. Well, a little bit about the scapula. It is a very interesting piece of our body. When we were pronograde, it was more or less perpendicular and more or less along the thoracic chest, and it slowly moved to the humans, when we became orthograde in a more position posterior to the thorax. And the normal motion is of the scapula is external rotation, upward rotation, and posterior tilt. We should always keep it in mind when we examine the scapula. And being a bone which is actually only connected to the clavicle and the humerus, it is just controlled by a big number of muscles. And that makes it so very interesting part of our body. Well, we are all familiar with the AO fracture classification, and it has been well used, but it is quite confusing and it is not very reliable. If you look to inter-observer studies, it is the types, it is the process, coracoid or the spine, the fractures, that is part, and the body fractures. And basically because it is not that reliable, there is a recent update of the AO classification on the scapular fractures, mainly body, fossa, and the processes. And I think that is easier to use and also for inter-observer use when we study cases. Well, it is quite rare. It is about only 3 to 5% fractures of the shoulder girdle. And we should realize this, 90% of associated injuries. It is normally a high energy trauma where the scapula is involved. And it is multiple injured patients. And like in this case, you can see here where there are several rib fractures combined with the scapula. So always look to the thorax because quite often ribs are involved and the scapula is broken. Well, regarding imaging, X-rays are reliable for a first diagnosis, but CT scan is basically, I think, mandatory to have a proper idea of how the scapular fracture is aligned. And CT scan is more reliable than the X-rays. And 3D CT scan is basically advised prior to surgery to get an idea. And I think Peter Cole from Minnesota has done quite long-term and studies also on large number of cases. And he is talking about 3 important criteria to decide either for surgery or conservative. And it is the so-called lateral border offset. If there is, and he suggests if there is more than 20 millimeter, you should consider surgery. But you should realize that the glenoid does not medialize. It is the scapular body which is lateralizing. And that can be quite considerable. The second criterion is the angular deformity. And you should have a proper look in the 3D CT scan, and if it is more than 45 degrees, according to Cole's suggestion, you should consider surgery. And the third one is the glenopolar angle. And you can measure it on standard X-ray, basically. If it is, and that is considering his series, it's a very interesting number. What about 23 or what about 21? So it's something you have to put in perspective. Basically, in his series, it was shown that if it is smaller than 22 degrees, you should consider surgery. And the combination of the lateral border offset and the angular deformity is a little bit less and a little bit less, then if it is combined, you should also consider surgery. What about the acromion and the spine? That is an old classification. I don't think it is very, very helpful. If you look here, there seems to be not much difference in the spine fracture here. So I prefer the Ogawa classification, where you divide it in 1, 2, or 3. And basically, the number 3 is at the basis of the spine. Since the introduction of the reverse arthroplasty, we see many more spine and acromion fractures. Well, basically, the number is not that high in the reverse arthroplasty, and you see it more in inflammatory arthritis. In the review of Patterson, about 10% of the patients with an rheumatoid arthritis and an RSA get an acromion or a spine fracture. And also in massive cuff tears with an RSA, especially because massive cuff tears are quite often more in the elderly, more osteopenic patients, you see a higher number of acromion and spine fractures. So, and it is also more frequent in the lateralized glenosphere. And there's a recent study that lateralization is giving a higher chance of an acromion or spine fracture combined to distalization of the RSA. But that is something for discussion. what about the acromion and spine fractures? Well, basically the acromion you can do conservative, and the spine, if displaced, you should, and most of them, they don't heal, you should consider surgery in an early stage. The coracoid process is quite rare, also the Ogawa classification, and type 1 at the base of the coracoid, and type 2 more distal from the ligaments. It is the coracoid fracture, which is quite unstable quite frequently. So what a question about operative of conservative. This is a picture sent to me from Oman, and he asked my advice what to do with this patient. Well, I think it's very much depending on how proper are your diagnostics in your place, and what is your experience, and what are your skills, and what are your local facilities. Are you well equipped in your hospital to perform this sort of more extensive and more difficult surgery? Do you have a proper anesthesia? If it is a multi-trauma patient, can you really deal with it? So I advised this guy who had not that very much experience just to consider to treat the proximal humeral fractures and leave it, because he found it too difficult and there was no one to help him around. So you should really consider these elements before you consider surgery. And Peter Cole had a very nice review of all cases in the literature treated for a scapular fracture. There were more than 500 cases, there were 22 case series. And he found out in that literature that all fractures with glenoid involvement, 80% had been operated by these surgeons of these series. And all scapular neck fractures without glenoid involvement, still many of them were operated. About half of the acromion and spine fractures without glenoid involvement were operated. And the isolated body fractures, generally 99% were treated conservatively. So basically, there is a tendency of surgeons to be quite aggressive in surgery on the glenoid and scapular neck involvement. We should consider that. But if you look then to the cases and compare the operative and the non-operative, and he made a distinction between excellent, good, or fair and poor. There were several classifications, but he just tried to combine them. And interestingly, if you look to the results in this large review where the glenoid only was operated, definitely had better, excellent, good results than the non-operative treatment. The same with the neck without or with associated scapular fractures, excluding the glenoid. Much did better with surgery, but still 80% did quite well with non-operative treatment. So it is not to say that you have to operate. We tend to operate. Like Dr. Tanner already said, as surgeons, we tend to operate, but it is not always necessary. If you look to the neck only, definitely surgery is better than the non-operative, but still 8 out of 10 do quite well with conservative. If you look to acromion and the coracoid, well, basically the non-operative did better than the operative treat. The body only operative did 100%, and it is quite understandable where there's no joint is involved. Normally they do very well, but 86% do quite well with non-operative treatment. And the spine only, this non-operative treatment, and this is not including the RSA series. These series are just the traumatic spine fractures. Many of them do quite well non-operatively. So if you look to these figures, and if you're not able to perform a proper surgery, the results are not that bad by going for conservative. Well, a little bit about surgical approachment, and probably Deepit will talk about it. This is the old-fashioned Dewey approach. You can approach the medial side of the scapula and the lateral side of the scapula, and as you hear, you go in between the infraspinatus and the teres minor. Quite easy to approach. The axillary nerve is still lateral from the teres minor, so that is quite easy to get it. You should take care, we talk about it later, for the suprascapular nerve if you approach the glenoid, but that is quite a wide approach. And recently it was introduced by Cole also that you can do it in a minimal invasive. You can do your lateral through a small incision here, medial to your deltoid, and here the more medial side, your angulated plate for the spine fracture. So that is quite easily to approach minimal invasive. So my take-home message is that isolated scapular body fractures, you can treat them mostly conservative. And in doubt, if you're not sure if there is extension to the scapular neck, use a CT. Neck and glenoid involvement, well, I think these criteria, they're well proven by Cole and also by other authors. Look to these three parameters and consider surgery if you think it is needed. And acromion, spine, and coracoid, if severely displaced, I generally consider surgery. Thank you for your attention.
Thank you very much, Dr. Williams. We're going to take the questions at the end of the session. I invite now Dr. Dipit to talk us on through the scapular fracture low threshold for surgery.
Yeah, just 1 minute. Okay. Is my screen visible, Pradeep?
Visible, yeah.
Awesome. So this topic was chosen by us, by me and Pradeep, that I have a low threshold for surgery. Basically, I think it has attracted, I hope it has attracted attention for everyone. But really, I have a low threshold for some fractures, not for all fractures. Most of the scapular fractures do well with conservative. I agree with Dr. Yap. Some of the fractures I do have a low threshold. And what are those fractures? Which of those fractures is what really I'll be speaking on? Which fractures I will definitely operate? And he's already spoken on some, but I'll just give examples, trending examples of one example in each category. For example, let's say this intraarticular displaced glenoid fossa fracture, which goes through lower 1/3. Also, there is a lateral border of scapular fracture, but that doesn't bother me. If you see the lateral border fracture is here, but this is okay. This is well aligned. Doesn't matter, maybe going to the body, but this bothers me because this is important to fix. And I do the Eidberg classification, and this is the most commonly fixed fracture which you will want to fix. This is a type 2 Eidberg, in which the lower 1/3 of glenoid fossa is fractured. So this is the type 2 Eidberg. We should remember this. The type 2 Eidberg is important to fix. Very easy to fix. You go posterior approach. You see the glenoid. You fix it with 2 screws. Easy. These are lag screws. The fragment sits back in place. And why is it important? It's just the risk of instability is high. If you leave that, there is chances of subluxation. So I do fix it. Now another example. So this is another 50-year-old guy. If you see this glenoid, first the glenoid is fractured. It's probably comminuted and had a CT scan, but it is 3/4 part, but it is more displaced than to my liking. So if you see, this is the type 6 Eidberg comminuted fracture of the glenoid fossa. Again, so my preference, you go in, you expose it posteriorly, you go in the internervous plane, and I'll show you later how to go in the internervous plane. But you go into the internervous plane between the teres and infraspinatus, you expose a fracture and you fix it with a recon plate. That is my preference, fixing it with a recon plate. You bend it as you like, 2 screws above, 2 or 3 below. You get a nice reduction, and probably these are the functions that you get at 2 years. Heals well. Most important, there may be associated fractures, but the most important is the glenoid, which I take care of. Now, risk of arthritis is what I'm really trying to get at, is what I'm trying to avoid in a massively displaced glenoid fractures. Now, another patient I got this. So this was a curiously interesting X-ray where the glenoid was fractured and the head was subluxated posteriorly. This is a definite indication for surgery in my hands. I went in. You treat both the subluxation is easy to reduce, but when you fix the fracture of the glenoid, you avoid a resubluxation, and this is the result at 1 year follow-up. So these are the fractures which are typically of glenoid I fix. The other fractures which are important to fix in my hands and to avoid stability. So this I used to do the medial plating. I do it no more. I think it is a lot of morbid procedure, a lot of dissection needed, a lot of bleeding. Mostly I just avoid medial plating. I have done it in the past. So now if I want to, I will fix only the lateral border through the lateral approach. And that too only if the GPA angle or the glenopolar angle is severely compromised. I don't go by Peter Cole's criteria. His criteria is 22 degrees, 45-degree angulation. I know that, but that is those series which he said, which he published as only his relative indication. They were not compared with anything, and they were not compared with conservative results. So even he mentioned those are only relative indications. So if it is severely compromised glenopolar angle or a very severe deformity, angular deformity, probably I'll go in and fix it. Most of them do well with conservative. And this is the video that I'm showing. This is my dissection in the dissection hall. So I just elevate the deltoid. I don't like to remove it. You see the infraspinatus below it, and you have to find the interval. Sometimes difficult, but you have to find the interval between infra and teres. Should not go below teres because those are the blood vessels, nerves at risk. So the interval between infra and the teres posteriorly, and the incision that I utilize is a vertical incision right over the joint. In the posteriorly, patient is floppy lateral position. I'll play this video again just to show you. So this is the arm is abducted, very important. Then you can elevate the deltoid or retract the deltoid. Easier seen in a cadaver, not so easily done in a human being, but you can still lift up or retract the deltoid and try and find the interval between the teres and the infra, which is the internervous plane supplied by suprascapular nerve and axillary nerve. So essentially, if you're going in an internervous plane, you are doing very minimal dissection. You're harming the structures less. There is nothing you are repairing back because deltoid is also lifted up or retracted up. You are not cutting it, and I don't like to cut it. Mostly, if it is to be cut, gives a lot of morbidity, the repairing back and all. So this is my preferred case approach to these fractures. Posteriorly, glenoid fractures, vertical incision, minimally invasive, if you want to call it, because it's going in internervous, intermuscular plane. And why I'm doing it is because it is avoiding instability, treating instability in some cases, and avoiding impending arthritis in the young age. Thank you.
Thank you, Dipit. We move on to the next talk, that is management of glenoid fractures. And I invite again Dr. Jaap Williams to take us through.
Sorry, wait a moment. I have to share the screen. Okay, can you hear and see me?
We can see you, but I guess we can see your screen also, but it's not full screen as it, I think. The presentation is not coming through.
Okay, let me have a check.
I think you can unshare and share again, and this time you check. I think you can stop sharing the screen and share again.
Yeah. Okay.
This time click on the PowerPoint window.
Yeah. Can you hear me? Yes.
Yes. Yeah.
Okay. Sorry for the interruption. Partly part of this lecture is already covered by Dipit, but we will talk also a little bit about the floating shoulder. I think it was defined originally as an ipsilateral fracture of the clavicle and glenoid neck. And interestingly, Gauss introduced the superior shoulder suspensory complex. I think that's quite important. These are the structures involved with this ring concept. And there are several parts of it. Here, the superior part, the acromion, clavicle, and these ligaments. the linkage to the clavicle, coroclavicle, and the AC ligament, and the third one is the bones, the acromion, coracoid, and the glenoid. And basically, if the ring is disrupted at two places, you have a floating shoulder. It is potentially unstable, not always, but potentially unstable. And if it is unstable at presentation, these are the problems you will encounter: delayed union, malunion, non-union, impingement, weakness and discomfort, and even neurovascular compromise if you have a drooping shoulder. As told already by Capil, the scapula is drooping and not the clavicle going up. Interestingly, if you look to a grade 5 AC dislocation, two parts of the ring are involved and it is unstable. But even in a grade 3, it is not that unstable. There is still rupture of the ligaments, but still not unstable. So it is potentially unstable, even the AC dislocation. Well, if you have a fracture of the clavicle and a fracture of the glenoid neck, what should you do? Well, either the clavicle is displaced or non-displaced, and the fracture of the glenoid neck the same, displaced or non-displaced. It is a consensus generally that at least one should be repaired. But when conservative, well, if there is no displacement at either side, you can go for conservative treatment. But in the case of surgery, if it is an open fracture, compromised neurofracture, vascular fractures, or multi-injury cases where it is easier to take care of the patient when you have a stable shoulder. Well, if the clavicle is placed, no bone contact or severely comminuted, after reduction of the clavicle, mostly you see a reduction of the glenoid fracture, the glenoid or scapular neck fracture. So the treatment of the glenoid is basically divided in two classifications: if the fracture is medial to the coracoid or lateral to the coracoid. And also if it is displaced minimally, which mostly is, or is it displaced more than 1 centimeter or 40 degrees of angulation. These are the parameters where you should consider surgery. Well, which dislocation of the glenoid can be accepted? Well, again, the glenopolar angle, and 30 to 45 degrees, that is normal. If it is lower, you should consider surgery if you think it will compromise shoulder function. You can do it on the 3AP or 3D CT scan. So less than 20 degrees might cause symptoms. It is not absolute, and it is definitely depending on how the patient is using the shoulder. You should individualize. In an old lady, probably it is different than compared to a young, active patient. So that is what you should consider. But you can get symptoms if the glenopolar angle is less than 20 degrees. Well, the clavicle, it has been discussed earlier, plating and take care of these structures. And I prefer basically anterior plating. There's less problem with the skin overlying, and you can quite easily bend the present day plates and using it anteriorly. The posterior approach, very nicely shown by Deepit. Normally, originally we went through the deltoid, but if you abduct your arm, as he showed nicely on the cadaver, you can avoid detaching the glenoid, and you can easily approach the interval between the teres minor and the infraspinatus. And that is the plane where you have to go to, and you can easily access it. Really take care of the suprascapular branch, the suprascapular nerve. It's very, very close, and you easily can, even already by using your hook with force, you can easily damage the suprascapular nerve. And I had one case where I cut it, but I damaged it. It became a neuroplexia, and it did not heal. So you should be really very careful for approaching the posterior glenoid with your suprascapular nerve. Well, the results of the floating shoulder, interestingly, there's also the same review I discussed earlier, that non-operative treatment of both scapular neck and clavicle in this series, excellent good results in more than 90%. Non-operative treatment of scapular neck and operative treatment of clavicle, 100% excellent good clinical results. Then operative treatment of scapular neck and clavicle, 93%. There is a little bit discussion about, it was not very clearly described how much dislocation there was, but nevertheless, there is definitely a place for conservative treatment, even in a floating shoulder. Well, this has been discussed earlier, the IDE and later adapted by BOS classification of the glenoid fractures. I think the AO classification, the more numbers you have in your classification, the less reliable. That is a general rule for all classifications, so I don't use it. But the glenoid fractures, basically there are two very important distinctions. Rim fractures, mostly due to dislocation, or the fracture of the fossa, mainly due to a fall, an impaction fracture. Now, the rim fractures very frequently with anterior dislocation, and here a case of the posterior rim fracture, and it is rarely inferior. And if you look to the rim fractures, if you do an arthroscopy, in nearly all cases, there is a piece of bone here. This is a chip avulsion because the labrum is attached quite severely here at the anterior inferior part. It's definitely something different than a rim fracture. The chip avulsion is nearly in all cases of a labrum avulsion visible. What about the inferior rim fracture? I had one case where the inferior rim, you can see it here on the CT scan, was avulsed. We have treated it conservative, and long-term result was very good. Stable shoulder and no arthritis. So that's interestingly that you can leave this, at least in the case I have seen, you can treat it conservative. Well, what about the rim fractures? There's a lot of discussion, and we all tend to be quite aggressive in doing surgery. But and there is quite evidence now in several series, if the head is centered, you can treat it conservatively. There's a very nice, very recent study by the group of Gerber, where they did a long-term follow-up in these rim fractures with very good to very good clinical results. So we shouldn't be that aggressive. Well, if you consider you can do it open or arthroscopically, there's quite some literature now available. This is a young patient I did. You can see here the small rim fracture, and you can do it quite easily arthroscopically. Well, I'm afraid figure's running. You can see here, it is not a very big fracture, but you can basically treat it as a labrum fracture. But if you have a proper device, you can pierce the piece of bone and get your suture from your anchor. So I put an anchor a little bit more of either an anchor superior and inferior, or in the middle if the small defect, and when it is in the middle, you can pierce the suture with this shuttle relay, pierce the suture through the piece of bone. If you don't like it, you can even pass it medial to the piece of bone and reattach it. And here you see like a mattress suture repairing this piece of bone. And here this is very small step off, but basically the glenoid surface has been restored. Well, the fossa fractures is type 2 to type 6 already addressed by DPIT. Basically, it is a general consensus. If the fracture capture is more than 5 millimeter or the step off is more than 5 millimeter, you should consider surgery. Well, if there's severe comminution, it might be very difficult to reconstruct it. If you have the plexus involved, I doubt if it is an indication for surgery, but it's something for discussion. I come up with some cases. This guy had a type 5A bicycle accident. You see here the CT scan, and the head was repaired elsewhere. Looks not very anatomically, but basically there was a persistent posterior subluxation. And very interestingly, it is the same case as DPIT showed, and it is mainly due to the malalignment also of the scapula. So I had to redo it, reconstruct it, but still not fully anatomic. And in 1 year, there was definitely beginning arthritis, but it's still a reasonable range of motion. So but at least you have a better position of the glenoid for, if needed, a total shoulder later on. Another case where you have a type 5A with the involvement of the scapula and severe involvement of the glenoid. And if you approach it posterior, from posterior, as you see here, It is nicely reconstructed and fully anatomic. So the glenoid was not involved here, but the scapular neck was involved, and with just a lateral reconstruction, as discussed earlier, this is sufficient to reconstruct this glenoid. It is a patient, 35 years old, had a direct fall on the shoulder, right dominant. It was a type 2 with some dislocation, as you see here. The treatment was conservative. Patient was referred to me, was treated elsewhere with a moderate painful joint, but no glenohumeral function and a very low constant score. And that referring surgeon asked me to consider an osteotomy. If you see here, there's quite a displacement, probably more than 5 millimeter. And you see here, so what should you do? Should you reconstruct it? Should you stay conservative, a release, or what else? Well, I first went in and did an arthroscopy, and there was a step off. There was definitely here, as you can see, the step off. There was some fibrous tissue in between. I cleaned the joint. I did an extensive capsular release, and 2.5 years follow-up. I had a full range of motion. So some of these glenoid fractures, they do quite well by treating them conservative. Well, there's a very old lady, a type 6 fracture. You see here a severe glenoid fracture and not very much displaced proximal humeral fracture. And what should you do? Well, basically, she was very reluctant to surgery. And at 1 year follow-up, she did quite well, even with this extended glenoid fracture. So some of these glenoid fractures, they are quite benign and do quite well. So in older people, I'm very reluctant to go for surgery. So the glenoid fractures, they are very frequent. Fossa fractures as well as floating fractures are quite rare. There is no full consensus of the treatment. There's very scarce evidence. Floating shoulder, well, I consider to do the clavicle, and depending on the glenoid, how severe the dislocation is, also depending the age of the patient, the activity of the patient, how aggressive I am. The glenoid fractures, if no containment, I operate, and if the gap is unacceptable, I operate. Thank you for your attention.
Thank you, Dr. Williams. Now I invite Dr. Ashfaq Hassan to take us through various approaches to scapula.
Okay. All right, can you guys see that? Can you all hear me?
We can
Okay.
see.
All right, great. We'll go through this. This is going to be a recap because some of this has been covered already. But basically, and I'm not going to spend too much time on indication. That's already been covered. But as we already heard, if you get displacement greater than 25 millimeters, angulation more than 45 degrees, and glenopolar angle less than 22 degrees, that's when could be a surgical indication. And then also associated injuries to the superior shoulder suspensory complex have to be taken into consideration as well. So your goals, of course, is to get adequate exposure to reduce and fix the fractures, yet minimize the soft tissue dissection and protect the neurovascular structures. Some of the approaches can be fairly extensive, some of the described approaches. And so the complications include, and the ones you want to avoid, of course, hematoma or seroma, muscular injury and or necrosis, especially in an iatrogenic injury, that is, nerve injury, and then of course you want to minimize the risk of infection. So this is a nice diagram. I like this. It really shows the outline in black of the areas of bone that you really want to, where you have good bone, right? So the middle of the scapula, of course, is just sort of paper thin. It's not really useful for fixation. The glenoid neck and the lateral scapular pillar, as well as the scapular spine and the medial border of the scapula are areas where you can put fixation if needed. And I would agree with Dippet. He mentioned earlier that he doesn't go immediately very often, and I would tend to agree with that. I think really where the money's at is lateral. That's restoring the joint and restoring the offset laterally, and immediately it's going to heal. And unless for some reason it's blocking a reduction in some form or fashion, extends all the way out medial, and blocking a lateral reduction, that is, yeah. Also, if you've got a scapular spine fracture, then that would lend you to want to fix that. So I like to place them lateral and with the arm in a sterile articulated arm holder. Certainly supine, a prone position has been described, and you can do that. I just find it easier to manipulate the arm when they're in the lateral position. You can place it over a bump as well. The sterile articulated arm holder sort of allows you to sort of position the arm in space where you want it. And then the classic approach, the classic Jude, and then of course the modified Jude, and even further modifications on that. So just to, you guys all know this, but just to look at it schematically, to get to the back of the scapula, of course, you got the deltoid, trapezius, and then you have the infraspinatus and teres minor, which are what you're going to have to develop your deep intervals through. In terms of accessing the deep structures, so it's been described to release the deltoid. I try and not do that, or if it's a really large individual where I do need to get access, a little bit more access, and then I will release perhaps a 2-3. If you release just 2 or 3 centimeters, that usually gives you enough access, even the very large muscular deltoids, to then do a deep dissection. And of course, you got to be cognizant, as Dr. Willems and both Dibbett noted, for the neurovascular structures. Suprascapular nerve, of course, is at risk. Axillary nerve, you're pretty safe with axillary nerve because you're working, between the teres and the infraspinatus, but you just have to be cognizant about that and the branch of the teres minor. Now, when you view the infraspinatus, finding the interval can be a little tricky at times, but there's some nice fat stripes that can help you out. There's a fat stripe right at the mid portion. There's 2 fat stripes. So the superior fat stripe marks the basically midpoint of the infraspinatus. And that interval is actually pretty useful if you're doing, for example, just an approach just to the posterior glenoid rim, for example, not inferiorly. And this would be typically not so much for scapular fractures necessarily, but I use this interval if I'm doing, for example, open posterior bone block. And then the lower interval, which we develop, is the second fat stripe to access to get wider exposure. Now, one thing I would note is that let me go back there. Sorry. So one thing I would note is that the infraspinatus muscle, the insertion rather, it stays muscular until way lateral. So you can really expose the posterior capsule. You can elevate infraspinatus tendon, or infraspinatus muscle rather, off of the posterior capsule and do a capsulotomy without taking down tendon, without releasing it off of the bone. And that really helps you rehab if you really want to try and avoid releasing the infraspinatus tendon if at all possible. And most times you can for the exposure you need. So this is the classic Jude incision. This is postlateral border of the acromion up here, and then you can see this boomerang type incision, pretty extensive incision, of course. And so the classic Jude was where you basically mobilize the entire infraspinatus out of its fossa and reflect it laterally, and all the way to get to suprascapular nerve. And then this gives you access to the entire scapula and to the lateral border and the medial border. But again, that's a pretty morbid procedure, and you worry about devascularizing fracture fragments. The counter argument to that is that this would be useful if you have, for example, a late fracture with tons of callus, and in terms of vascularity, you know that the subscapularis anteriorly is obviously a very big muscle that helps preserve vascularity. But this is an approach I do not do, and I don't think many people do anymore. And the modified Jude is using using intramuscular windows for the deep dissection, as we already heard about. So you develop the window laterally between infraspinatus and teres minor. If you need to go medially, if you feel like you need to contour plate medially for whatever reason, you can then just develop the plane between the rhomboids and the infraspinatus, leaving some cuff for reattachment, and then place your plate there immediately. So this is a nice study by Harmer et al., and they compared the amount of exposure between the classic and the modified Jude approaches. And they found that the medial and lateral borders, the full medial and lateral borders of the scapula could be exposed through either approach. So really the areas you need to get to put your fixation. But with the modified Juget, only 20% of the scapular surface was exposed compared with the traditional Juget, classic Juget, which basically the entire scapula was exposed. And of course, this has significant advantages in morbidity and potential devascularization and potentially even injury to the suprascapular nerve. We've seen this slide already by Dr. Willems, but this is, I think, a nice way to do this, targeted approaches, where you just use targeted incisions, minimally invasive, to get your fixation where you need it without having to do the entire reflecting approach. Now, what if you have concomitant injuries? If you have a clavicle fracture, and if that clavicle fracture you feel surgery is indicated, is displaced and shortened, and you feel it would stabilize, then you want to fix that first. You can do that any way you want, really. I prefer to do that supine. I do all my fracture surgery, proximal humerus and clavicle supine, and then flip them to a lateral position. It is important to note that the clavicle ORIF has not been shown to aid in reduction of a scapular fracture by ligamentastasis, right? So the goal of the clavicle fracture should not be that you're hoping that's going to somehow aid your reduction, because it's not. It's really to help restore some stability, additional stability around the shoulder girdle. So this one case I'm going to show is this 38-year-old veteran motorcycle accident about 4 days ago, and comminuted fracture as well as a clavicle fracture. And you can see he's got angulated, not terribly shortened clavicle fracture, but significant medialization of the glenoid, or really lateralization of the scapular body. And he had angular deformity, which you don't appreciate on these films, of course. Traditional Judet incision. And again, this is what we talked about earlier about, and he was a pretty large muscular guy, so I think I released about probably 2-3 centimeters of his deltoid immediately and reflected it laterally. Now, one thing to note is that you do have to be cognizant of the ascending branch of the circumflex scapular artery when you're working this interval. And that's usually around 5 to 6 centimeters medial to the glenoid rim. And you want to look for that and ligate it if you come across it, to avoid any significant bleeding. And again, this is just a diagrammatic representation of the intervals. And you can see here, and that's what we're talking about here, is that superior fat stripe, which is really marking the middle of the infraspinatus. Here's a teres minor, and that's interval you're going to develop. Brings you right down on it. And here you see us marking that interval. And this is, you can sort of see the fat stripe here in the middle of the infraspinatus. And then you get this lateral exposure, and this is a little trick described in the literature by Vremsky, where using these 2.5 millimeter Shands pins from the small fragment, from the small external fixer set, that really helps you to manipulate the fracture back in place. And as we noted, that the scapular body is relatively lateralized, and so this can really help to reduce it. And you can put a retractor, additional retractor laterally. I'm using a cob here to help reduce that lateral distraction. Now, if the fracture goes up into the where you have rotation of the inferior glenoid, releasing the long head of the triceps is very helpful, because that's a significant deforming force. And you can release that to help with the reduction of the inferior glenoid fragment. And this is a scapular-specific plate that you can see. And then at this point, we can basically let that interval fall closed. And these are post-op films. This is actually not his films, obviously, because we used a recon plate here. But that's essentially you can run your plate really all the way up, just proximal to the spinal glenoid notch, and then get good fixation down the lateral side. Now, in terms of the plate placement, you can also run the plate. We got this plate posterior medial, but you can run the plate straight lateral depending on the fracture configuration. And those screws that go lateral to medial will give you much longer screws than ones going from posterior to anterior. I think that's just the same film. So in terms of closure, you just allow the intermuscular intervals allowed to fall closed. If you've taken down some of the deltoid, then it really should be repaired through transosseous drill holes. You don't want to lose any part of that posterior deltoid. Drains as needed with that big flap, and you want to definitely put some stitches to close out any dead space. Lightly compressive dressing. I just put some extra ABD so that if there is a flap there to allow some light compression, passive range of motion, and initially and an active range of motion at 6 weeks post-op.
Great. Thank you, Dr. Hassan.
Sure.
Pradeep?
Hello. Yeah. Thank you, Dr. Hassan. So regarding, I have some questions from Dr. Hassan. Hello. Yeah. So just let me share. 1 minute here. So we don't discuss much about the approach that is been described in the lower part of the screen. That is the approach that is been described for the clinoid fractures. Like instead of taking the minimally invasive straight incision, which can damage the clinoid, this modification, if we do, which is ideally described for the clinoid, this can help us to titrate the approach. What are your views on this?
So you're talking about doing a deltoid. I'm trying to see if you're showing me here. Deltoid split here?
No, just take the skin incision like that.
Oh, skin incision. That's skin incision. Okay.
Yeah. So the Jude incision is like this L.
Yeah, right,
so,
right. So reverse Jude incision, basically.
Yeah, reverse Jude incision. Yeah.
Yes. Yeah. No. I think that's a great question. I think that definitely, if you know you're going to be doing just lateral work, which most of the time you are, I think that's very reasonable to do that incision. Absolutely. And because that goes in with your more limited approach, and depending where you have to get to, and depending on what the fracture configuration is, I mean, you could potentially even just do this through a deltoid split, right? I mean, you can get, if you do it through deltoid split, you just got to remember that. And if you're trying to work through the interval of the teres minor and infraspinatus, that's pretty far down, right? That's a good 7 centimeters down if you're going to do that. But yeah, no, absolutely. A reverse Jude incision, I have used that, yes.
So this minimally invasive causes more of a deltoid damage. What is your take on that? Do we really the straight incision, only straight incision? Because we have tried it and it requires a lot of deltoid retraction. Even if you abduct the arm, some fibers of deltoid can get damaged.
Yeah, I mean, I think if I'm understanding your question correctly, I mean, for my incisions for the posterior shoulder, it's usually some sort of J or gentle L incision, because I think it does help just to get some better exposure. I mean, your skin incision again is, is just trying to position that perfectly. But is that, am I answering your question correctly? I'm not sure.
I think yes. Yeah.
What he's asking, Dr. Jab, to you too, if we do internervous approach through a deltoid retraction and not a deltoid removal approach, would it damage the deltoid more in that case, because you don't have a very good exposure? So you're trying to retract the deltoid more and more because you've not removed it, and in an occasional large person the exposure may not be good, so you may end up damaging more of the deltoid than if you just remove the deltoid from the spine and then repair it. Is that correct?
Yeah. Just to share the experience, basically, that if we take this case, if we take this reverse L incision, then it gives us little bit more space to make that basically take a snip onto the tendinous portion of the deltoid here medially, and same minimally invasive approach can be taken, means same entire skin in the muscle interval would be same, but just the addition of this horizontal limb help us to retract the deltoid much more effectively without damaging it. That's what I was trying to say. But we don't see it much discussed, although in shoulder technique this approach has been described.
Yeah, I mean, I think if you're worried about a big deltoid, I mean, I think you just, like I mentioned in my talk, you can release just 2 or 3 centimeters of deltoid medially, and that helps then you retract the deltoid laterally, because it can be quite difficult if it's a very big deltoid and you're leaving it completely intact, just to get over all the way lateral. So yeah, but again, I would just say, just make sure you repair it back through drill holes. Drill holes, Mason Allen stitches for the deltoid repair at the end of the case.
One question for yes.
My approach is more or less the same, but what I start with, the skin incision is not the most important, but the most important, and Deepit showed it nicely, I heavily abduct the arm, and if I'm able, without too much retraction of the deltoid, to approach the posterior glenoid, that's okay. If it is too bulky, then I take a little bit of the, as a second step, take a little bit of the deltoid. But I start with the full abduction, and I hardly ever need a detachment of the deltoid with that abduction, that extensive abduction.
One more question to Dr. Yap Williams regarding the isolated scapular spine fractures. They are rare, but we do get them. And traditional teaching is that we can manage them conservatively, they heal obviously. However, since the deltoid pull is laterally, can it cause later impingement and problem? Because when we see the literature, they just focus on 5 years, 10 years. But since the scapular spine displaces like that downwards, can create a lateral sloping acromion and later problem with the rotator cuff tear or impingement like that.
Well, I think we should distinguish between the traumatic in the younger patient or the spine fracture in the elderly. Different. But in the traumatic cases, generally the displacement is not that severe and you can accept it. If it is a very severe displacement, but that is often combined with other parts of the scapular fracture, then you should address it operatively. But I have not seen in this small displacement a supracomoral problem later on. It's different with the RSA patients, the reverse patients, and it's mainly partly due to the osteopenia, but definitely there is distraction due to the lateralization, what we more and more do now in the reverse arthroplasty. And these patients, they very often develop a pseudarthrosis and painful spine, and then you have to address them operatively.
So Dr. Willems, how often when you have a patient with a reverse arthroplasty and comes in with a scapular spine fracture that say it's a little widened and it's a little displaced, so what's your treatment algorithm for these patients? Do you automatically fix them? Do you try to non-op initially? How do you approach them?
Yeah, I try 6 to even to 12 weeks, try to do conservative. They're mostly elderly patient. That is another argument. They don't like another surgery. So generally they accept to start with conservative treatment. And that can be, if there is in 6 weeks not any progress on my X-ray or CT scan after 6 weeks, then I proceed to surgery. But if there is callus formation and a little bit tendency to healing, then I proceed with my conservative treatment. So it is a little bit depending on the...
Yeah, is there any role in your mind, because presumably they got the fracture because they're overtensioned, right? I mean, so is there any role to go in and downsize their poly?
I never did it because I'm afraid of instability of the shoulder. So I prefer to address the spine fracture and leave the RSA as much as possible, and because making the reverse unstable by decreasing the lateralization, which might happen, which luckily I've not seen, but might happen. So I'm a little bit reluctant to address the prosthesis itself.
Yeah, there's one more question that is to all faculties. Many of this time, these scapular fractures have associated moral levely lesion. So does it affect your management, the surgical protocol or the approach per se?
Sorry, I didn't fully understand your question.
Yeah, so many times this scapular fracture, the run over injury, they have the moral levely, the internal degloving of the skin.
Yeah.
Abrasion. So does it affect your treatment management? And how much importance that you will give to the skin lesion, internal degloving?
This, you mean skin lesion if the,
Yeah.
at the trauma? Yeah.
Yeah.
Well, you can still wait 10 to 14 days before treating the surgery. So you can wait how the skin is healing. So there's no urgency to do it immediately.
Yeah.
Unless there is a multi-trauma and there is an indication to do early surgery. But generally you can wait and see what the skin is doing. I don't know what Dr. Hassan thinks about it.
Yeah, no, I agree. There's absolutely no urgency on that. You let the skin heal and come back and do it in a couple of weeks.
So I think Dipit, we can move on to the next session.
Yeah.
So next session would be an interactive case discussion. I invite Dr. Didi Tanna sir, Dr. Sangeet Gawale to join us for the panel discussion. And Dr. Dipit is going to take us through the case presentations and generate the discussion, highlighting the treatment principles of these uncommon injuries. Dr. Nicholas Santao could not make for it. So in his absences, I would like to be there.
Yeah. Can we have the video on for all the faculties? Pradeep, Tanna sir, and Dr. Gawale is here?
Dr. Gawale is there, yeah.
Gawale sir, good morning.
Good morning.
Okay, and Dr. Jap Williams, Dr. Hassan, and Dr. Kapil, are you here?
Yeah.
So I'm going to show you certain cases and cases from my practice and cases which I've seen an increase very recently. And we'll take you through the learning process and what are the learning points. Basically, what I think, neglected shoulder dislocation is not that uncommon as people think. I'm seeing it more and more now for some reason, more so because of the lockdown period. Some of these, and I think most people would agree over here, at least we got to see more neglected cases, not only neglected dislocation, but other neglected cases sort of had a recent brief spurt. And there are no standards set for the management of neglected dislocation. Experience is also very limited. In fact, you'll be surprised to know that there is a landmark paper by Rowe et al. What he said was neglected anterior is more common than neglected posterior. Although neglected posterior, intuitively is missed because of single plane X-rays. But neglected anterior for some reason is also common. Shoulder replacement also is a very complicated procedure in a dislocation case. So how I'm going to do is I'm going to show you a case, then we'll go one by one. We'll start with Dr. Tanna sir, and then we'll go to Dr. Gawale, and then Pradeep, and then we'll go to Dr. Yap Williams, Dr. Hassan, and Dr. Kapil in that order. And I'm going to ask questions. Let's learn a bit with these cases. So I'm just going to show you. So this guy is presenting after lockdown. So lockdown gift, 4 months, the injury, he had a fall from the bed or something and had a dislocation. Probably somewhere in the beginning of April or maybe late March, and he tried to get out of his village, but the local police just sent him back to his home, and he got 2-3 lathi charge also at his ass, could not reach to any hospital, and presented to us. So this is his range of movement at 4 months. He's mildly painful in that range, but beyond that range, he's very, very painful beyond the range. External rotation is absolutely not there. Don't have the picture, but there is no external rotation. It's 0. The internal rotation is also limited till the SI joint. Movements are painful. Now, so this essentially is a 4 months old neglected anterior dislocation presented to us immediately after partial lifting of the lockdown. So first question, any role of close reductions? Tanna sir? No. Would anyone differ? Dr. Gawale sir? Are you here?
4 months. So there is no role of close reduction.
So Pradeep, would you agree?
Yeah, only if you want to create a spiral fracture of the humerus.
Correct. So everyone agree, Dr. Hassan, Dr. Kapil, and Dr. Jab?
Correct. No role.
So no role, nobody would try a close reduction, correct?
Correct, yeah.
Now, so next question is important. Now, I've had papers, and this is a very common discussion point among many surgeons. Some do say that there is a risk involved in doing anything to it. And there is a book quoted by Dr. Mohapatra. He said, just leave them, they do good. So would anyone consider conserving it, leaving it like that? We'll start with Dr. Nasser. Tanna sir?
Sorry.
Yeah. So the next question is, would you consider conserving it or just leaving it like that?
17-year-old, as I understand.
17-year-old, yes.
No, I would not conserve it. I think 4 months is not so bad. I'll go ahead and do the open reduction, but I'll need a CT scan before that.
Right. Dr. Gawale, what would you say?
Anything, something more to add, unless he is mentally retarded or he has some medical issues wherein surgery will be difficult. That would be the indication for conserving him.
By any chance? Is he epileptic?
No epileptic, no other medical procedure. As I said, it was only purely due to lockdown that he got neglected. He could just not go out of, and this is the reason why he got neglected. So no other comorbidity, no other fracture, and nothing else along with it. But no other reason not to operate, means there's no medical comorbidity. So, Pradeep.
I think it's being straightforward, because such a young patient, we need to reduce it.
Correct. Dr. Hassan?
Agree.
Dr. Jab, would you differ?
I agree.
Okay, and Dr. Kapil, any other differing views on this? Dr. Kapil? He's maybe offline. He's not there? Okay. Anyway,
He's there, but I think must be network issue. He's there. Yeah.
Okay. So we'll just take these questions. So what are the surgical options? What is your preferred approach? So I would want to hear more than one option if there is. What are the options? What is your approach? And what are the challenges in performing a surgery? Tanna sir, we'll start with you.
I presume you're not taken a CT scan.
There is no, I don't have it right now, but there was nothing else involved. It's a dislocation. There is always a, Hill-Sachs.
Glenoid part of it, because I think at the moment in the X-ray, the hair appears to be all right, but the glenoid, I'm not sure.
No, there's no fracture in the glenoid.
Yes, I'll do the anterior exposure, anterior standard exposure, and you will be able to get it back. You'll have to really do the fairly good amount of soft tissue dissection in order to release the head.
Right. So, what are the challenges? Do you foresee any challenges?
Not really, except I think you'll have to go down and go on, be patient and go on taking out the soft tissues, whatever is restricting. And ultimately, the main challenge is going to be at the end of it. When you reduce it, it may not be stable. So you'll have to probably stabilize it. And I would like to stabilize it basically from the acromion to the head, put in a screw or a stem or some.
Right. Dr. Gawale sir, what would you say? What are the surgical options that you can think of, and what is your preferred approach?
Apart from what sir has said, I would need a CT and MRI both. MRI to know the labral and the capsular tear so that I can repair and address it at the same time. Second, CT scan to know the size of the Hill-Sachs lesion. Unless I know the percentage, whether I need an additional procedure like a autograft or an allograft or a lethargy, I won't be able to decide, and I should not operate without having these two investigations.
Right. So, what are the challenges? Do you, if there is no other labral, of course, may be torn always in a glenoid, in an anterior dislocation, but there is no fracture, and the Hill-Sachs is always there, but it's not very deep.
But in a neglected fracture, the question of a recurrent dislocation is not really much there. The question is the stiffness.
Correct.
I don't know whether you are going to need a lethargy or any of those for a recurrent shoulder dislocation.
Correct. Pradeep, what do you think?
I think I share the same view as Nasser, that no, in recurrent, in this thing, the recurrence is not much of a problem that we are looking at.
Right.
But
Dr. Jap.
Yeah, well, I think the Hill-Sachs lesion is quite important, and normally in these cases it is quite deep because it is already 4 months old. So I would probably address the Hill-Sachs lesion depending a little bit on the size, and I use allograft. Regarding the approach, I go for delta pectoral, and I think Pradeep showed very nicely. I open up the rotator interval, or I remove the biceps, doing biceps tenodesis, and try, without detaching the subscap, to reduce it. If that fails, sometimes you have to take off a little bit of the superior part of the subscap to reduce the head. And the rehab is quite important, but maybe we will address that later. But I would be probably, there might be, because this 4 months old, dislocated, it might recur easily. So I would probably give a spica and or a brace with the arm in a neutral rotation to prevent a redislocation.
So you will give a spica or a brace in which rotation would you say? 0 degree rotation?
0 degree, neutral rotation, yeah.
No, why not internal rotation? It's the most stable internal rotation, right?
Yeah, well, your subscap is relaxed and it still can easily pop out anteriorly, even with an internal rotation.
Okay, interesting. So you think neutral rotation is more stable than internal rotation?
Yeah, keep the subscap under
Hassan?
tension.
Yeah, I think.
Hello. Yeah. Yes, Tanna sir.
As I had mentioned to you, that after the reduction is going to be not very stable. So,
Correct.
some plaster spica, as I mentioned by Dr. Williams, I would rather put in the screw or a Steinman pin through the acromion to the head and make it stable there, and then it should be stable. And this is what I've been doing it, and I've been quite comfortable doing that. I would avoid the implant going through the head and through the glenoid in the joint, because I would obviously put something which is extra-articular to keep the joint intact.
Right. Dr. Hassan, you were saying something. Yeah.
Yeah, I mean, I think, a couple of things. I think I agree with, you'd have to really assess the size of the Hill Sachs with this chronicity and see how big it is. The other thing is it's been sitting out for 4 months. Even though there may not be an obvious glenoid fracture, you may have, sort of Walsh B type bone loss, right? Where you have this attritional bone loss of the glenoid. So you've actually lost AP diameter. I mean, I think the challenge here, well, there's going to be 2 challenges. One of the challenges is getting it reduced. It's going to be really stuck out there and it's going to want to, and the second thing is going to want to go back out. So I would consider doing a Latarjet with this. It will do 2 things. One, it will now, assuming you have to look, he's only 17, so you have to make sure his growth plates in the coracoid are closed enough to do that. But assuming they are, the Latarjet gives you a couple of advantages. One, it helps with your exposure and helps perhaps, with your reduction maneuver. Then you can, again, assess your Hill Sachs, see if you need to fill that defect. And then the Latarjet gives you the advantage of increasing your arc and give you the sling effect. Because I think your main challenge here is going to be, keeping this thing stable. This thing's going to want to come back out again.
Okay, great. Interesting. Dr. Kapil, are you on?
Yep.
Okay, what would you say? What are your views on this? Any different views? Anything that you like to add?
I would agree with the pre-op CT to assess the bone loss on either side. I think for me, the biggest challenge would be reduction. And yes, you would try and preserve the subscap to do a reduction, but I think that would be a bit of a challenge. It's stuck into the coracoid. So whether you detach the whole of subscap or you detach the top half, but then depending on what my pre-op CT shows, if there is no significant glenoid bone loss, I would probably reduce it and then do an anterior capsular plication or something to reinforce the anterior soft tissue, because that's where his bagginess in his capsule and laxity will be. That's where he'll try and redislocate. I personally would avoid putting anything from the acromion to the head, just because it's non-anatomic. It will probably need to be come out later on. And I worry about transgressing through something from acromion to the humeral head. So I will try and rely on my soft tissues. But as said earlier by Dr. Hassan, if there is bone loss on the glenoid side, then have a low threshold for doing a Latarjet or a bone block, depending on what your preference is.
Correct. Interesting. So how would you do the what is your approach for doing the capsular plication? Then would you be removing the whole subscap?
No, you can do it through a subscap split. So you can split the subscap. If you manage to reduce it without detaching the subscap, then you can do a subscap split like you would do for a Latarjet, and then you can pull up the capsule and do an anterior capsular plication and address any labral pathology as well as you would do for an open bank card, for example.
Correct. So yeah, so there are a couple of learning points here. Those are good. I agree with them. So good points here. Any
Kapil,
neuro?
if I can ask,
What is it, sir?
if I can ask you, after 4 months, would you be able to get the capsular repair done after 4 months? Because in order to reduce this anterior dislocation, you will have to probably quite a good amount of capsule you'll have to release it. So will you be able to get this back?
Yeah, Dr. Kapil, what would you say?
What I would say is that if you, whatever the capsular labral complex you can get inferiorly, because that is where the whole thing will be stretched out and rest, yeah, and reinforce that soft tissue in the front to form that anterior soft tissue restraint from going out. That's what you will try and do.
Okay, so next question: what are you afraid of any neurovascular complications if operated, and what results can be prognosticated? Tanna sir, would you go at this first?
Stiffness is going to be the major thing, so that after it is stable, you start mobilizing. It may take about a year to get the decent range of movement into these situations. But I don't think neurovascular is much of an issue.
Dr. Gowale, are you here?
Yeah, I'm there. Probably a longer incision and retracting the conjoint tendon, or
Right.
plus minus the osteotomy of the coracoid would
Correct.
avoid that injury.
Correct. So, but is there any, have you heard of neurovascular complications, or should you warn the patient about any neurovascular complication, and what are the results to be prognosticated? What will you tell the patient? Will he have a reasonable range of movements?
No, there are two different things you are asking. The range of movement, obviously, there will be some restriction considering his impaction in the humeral head and the restriction what he would get subsequently. Second part is the neurological deficit. It's unlikely because the head has not shifted far medially. It is still outside or just underneath the glenoid or the coracoid.
Correct.
It is not sufficiently medialized to have that much of dissection and have a risk of brachial plexus.
Correct. I agree. Dr. Jab?
Well, the axillary nerve can be involved, can be stretched out, and if the axillary nerve is intact, it probably will remain intact after the surgery. Regarding the rehab, basically the head as well the glenoid have been devoid of the natural nutrition of that cartilage. Right. So the cases I've done, most of them, they develop arthritis on the long term. And luckily it is quite benign, but I tell them that they will have probably an arthritis on the long term.
Right. So arthritis may be expected, yes. Dr. Kapil and Dr. Hassan, are you here?
Yep.
Kapil, yeah.
Yeah, I would agree with Yap. Axillary nerve is your concern, and long-term results, I don't think you'll have a completely pain-free full range of movements. There will some range of movements is expected. It depends on how much chondral damage do you find. It's been out for four months. If there is some chondral damage, there may be some ongoing pain and discomfort, but I don't think you'll get a normal shoulder after this.
Yeah, there will be some restriction. Would it be painful?
It depends on how much chondral damage there is when you go in. And sometimes you go in and the whole cartilage just peels off. As Jap said, the cartilage has not had nutrition for 4 months. So it will depend on what you find there.
Correct. Dr. Hassan, anything to add?
No, not really. I would agree with that. I mean, he's gonna obviously a higher risk for osteoarthritis. Axillary nerve is clearly the one that's at highest risk, I suppose. But I think it's pretty safe. I mean, as long as you follow standard procedure.
Yeah. So those are the things in mind when you do these cases, but operate on them. So I just open reduced it through deltopectoral approach, remove the top part of the subscap because it wasn't possible to get it back. So remove the tendinous part, but retained the muscular part of subscap. Did not do a coracoid osteotomy in this case. Did not stabilize with acromiohumeral pin, but although that is always an option, because if you find instability intra-op, I would have fixed it acromiohumeral. This is the immediate post-op. This is the post-op 1 month. Okay, immobilized in internal rotation for 1 month, and then we started exercises. This is only 4 months follow-up. Of course, no pain, but its range of movement has increased tremendously. It is still limited, but he's doing much better. external rotation is also improved a lot. The most important is the rotation is improved, and the internal rotation, external rotation. But yeah, those were the points in mind when you go in. Of course, then it depends on how much of a bone defect is. There wasn't a much or a big bone defect. This is 4 months follow-up only. Okay, so let's move on. I'll just show you another case. Okay.
Deepit, can you hold on?
Yeah.
Why the head looks flattened?
Which one? In this X-ray?
In these X-rays.
There was a small bone defect, so it's because of that maybe.
It is not spherical.
So we will probably go in. But if it was a year, because we do see them quite often, people coming from the
1 year.
villages a long time, 1 year later.
Correct.
You go in.
1 year later, I have done, yes, sir. But those are more complex. This was not that complicated. Means I did not have to do a coracoid exposure, did not have to fix it. But at 1 year also, of course, I have done it. But those are more tough because the glenoid has even absorbed or there is a bigger bone defect in the glenoid, much bigger, because they keep moving the humeral head on the glenoid anteriorly, so the glenoid keeps on getting eroded. So you end up with having a 30 to 40% glenoid defect in those cases. I agree, those are more difficult. But I have examples of those too. I've not included them. These are strictly straightforward ones. But
if it is a year or so, they develop a reasonably decent painless range of movement. And probably it may be worth just leaving them there.
Yeah, no. So if they have a painless, good range of movement, I've seen some of them wouldn't do it anything. It's only when you don't have a good function and you are painful, then you do it. So this is. I'll just move on. Okay, so this is again 4 months old. 50-year-old guy, and it is posteriorly dislocated. Okay, in axillary view, it's very easy to make out. Posteriorly dislocated. So this is the movement. So no external rotation at all. So these are fixed in internal rotation. He's having around 80 degrees of elevation. The rotation is severely limited. Okay, so this is actually in minus 20 or 30 of internal rotation. He's not even 0 degree of external rotation. He's relatively mildly painful only in this range, and of course he doesn't do more. So questions in this case: should you attempt close reduction? Can you leave it alone? And what are the limitations if left alone? So Tanna sir.
There is no question of close reduction. You won't get it close reduction.
Right.
And obviously, I presume he is not epileptic because this
no epileptic.
Very common among the epileptics.
Correct.
So if it is not epileptic and if it is otherwise, he is a young man, I'll still go down some anterior approach, try to reduce this.
You would approach it surgically, correct? What are the limitations do you think if left alone?
Range of movement.
Range of movement, right. Dr. Gawale sir?
I'll still try to do it. It is only 4 months. 4 months is not that bad.
Correct.
If it's a year or so, then I would be very hesitant to go down, as I mentioned.
Right, but would you approach it differently than anterior? I mean, in your mind, would this be like much better prognosis than anterior?
I would think anterior will be much better there.
Much better. Okay. Dr. Gawale, would you add to this?
Yeah. Can you go back to the last slide, which is a very classical sign? Yeah. In a forward elevation, they cannot supine it.
Yeah, they cannot. Correct.
So this is very classical. The
second
photograph. And deltopectoral approach, I would open it. Obviously, again, there is no reverse Hill-Sachs as the head appears spherical, but still, I would need a CT to know if there is any Hill-Sachs lesion.
Okay, Pradeep, are you there?
Yeah.
Anything to add in that?
No, I think that is everything has been said. The approach would be anterior and McLaughlin procedure.
Okay. Dr. Hassan?
Yeah, I mean, I definitely want a CT. I mean, I can't tell for sure here, but that looks to me like there very well could be a pretty decent sized reverse Hill-Sachs. It looks like it's locked posteriorly. I can't tell for sure in a CT. Do you have a CT?
And not here, but it was around 20-25% bone defect. This is always there. What exactly are you thinking when you're thinking about the bone defect? What is your concern?
Well, I mean, I think you got to do something to fill that defect, right? I mean, I think
Right.
that because that's going to put them at a high risk for redislocation. So depending on the size of it, I mean, you have your options, right? You can do McLaughlin, you can do, modified McLaughlin, or you could do allograft, depending on how big the defect is.
Correct. Dr. Jap, are you there?
Yeah, well, I agree. There is definitely a reverse hill sex. All these cases, they have a reversed hill sex, and quite often it's even rather deep. I'm a bit reluctant nowadays to use the McLaughlin. Basically, you change anatomy and you make it a little bit more difficult. If you need later on a total shoulder, then your subscap is in the way, actually. So I prefer an allograft.
Allograft.
Standard allograft.
Fantastic. Dr. Kapil?
Yeah, I would agree. Need a CT, but I'm sure there will be a reverse hill sacks, and depending on the size of the hill sacks, I still do a McLaughlin, although I started using sort of a double row anchor technique to fix it. And whatever the ones I've done, I've been quite pleased with the functional outcomes. So that's what I would do here.
Okay, so those are the surgical, of course. So your choice of treatment, we'll go quickly with Tanna sir. Choice of treatment and prognosis.
Prognosis at 4 months is fairly good. I think if you're able to correct the, I also will feel that anterior exposure is going to be good enough that we get a good prognosis at 4 months.
Choice of treatment, sir.
Open reduction, therefore we have discussed it.
Yeah, there will be a hill sacks. So for example, some people said.
No, I'll do the McLaughlin.
McLaughlin. Dr. Gawale, sir?
Yeah, the same thing, because it doesn't appear to be more than 30 or 40% because that defect would have been obviously seen in X-ray as well. So the treatment of choice would be a McLaughlin.
McLaughlin in your case. Okay. So Pradeep, McLaughlin you said, right?
If I can add up the bit.
Yeah.
Same situation with a fresh fracture.
Fresh fracture.
It is a fresh, same. There is a hill sac which is there in a fresh injury. Would you still do the McLaughlin? Because I have been able to do it in these situations. You can elevate the depression which is there in a fresh fracture. In the gap which is created, you put in the graft, try to reconstruct the head, and you will be able to do it in a fresh fracture very well.
You mean one dislocation, acute dislocation?
No. I'm talking about a fresh is about 5 years old or 8 years old, which has not been able to use it, and there will be a reversal sac.
Correct.
So that reversal sac you can elevate it and put in the graft inside the head and try to get that whole thing elevated up what is depressed.
Right.
I think one thing that needs to be discussed, I think, is the reduction maneuver. I think there are a lot of when we discuss a lot, many people like to do it different ways. So one thing
so
I have
Pradeep, what would you say your reduction maneuver? How would you reduce it? Let's say you've opened up and you've removed the LT. You are going to remove the LT for sure. And
so one thing which I found is that the locking mechanism in an extended position completely reverses, is completely changed when you flex it. So if the shoulder is locked in extended position, and if we open it and we flex it, it becomes much more easier to unlock it by just putting some wedge kind of device, and the jump distance can easily be overcome rather than doing it in extension. So rather than struggling a lot in extension, I think the best thing which I do is flex it. After opening and everything, you flex it, a little bit of wedge inside, and the jump distance can be overcome, and it reduces very well.
Right. Dr. Hassan, are you there? So what is your take on that reduction maneuver?
Yeah, I mean, I think, so I would do, to approach this, I would do lesser tuber osteotomy to get the exposure. And even if I'm doing I typically do an allograft. I do a fresh allograft for this. Although I don't know if you absolutely have to have a fresh one, but I think that's advantageous. And then once you get that reduced, I sort of just slip sort of a joker in there, and you're able to sort of, gently, you don't want to obviously torque this too much, but you can gently maneuver it back in place. I don't find that too difficult. Once you got the lesser off, it's not that difficult to get it back in.
So yeah, Dr. Jap, any difficulties in reduction maneuver or difficulty in reducing it?
Well, I generally manage to do it without an osteotomy of the tuberosity. Just open the rotate interval and also take off the superior part of the subscap if needed. And I gently manipulate, and depending on the position, I use a blunt Hohmann to level out the head from posterior, and that generally works out well. And then, then address the reversed Hill sex with an allograft.
Allograft.
And use a brace as well for postoperatively in the neutral rotation.
So anytime you had to approach from the posterior end or no?
Never needed, no.
Never, okay. Dr. Kapil?
Regarding, maybe some comment regarding the acute case. I agree. I think Dr. Tana said it, or Dr. Hassan, that you can level out the cartilage, put bone underneath, and restore the congruity of the humeral head. But I think it is absolutely mandatory in acute cases to do a CT scan. I've seen cases done close reduction without the CT, and the occult fracture of the humeral head was dislocated, and then you have a serious problem in the acute cases. That's for the acute cases. Yeah.
Dr. Kapil, you have to add something?
No, agree with everything. Delta vector approach. I do an osteotomy. For reduction, I would flex and internally rotate further, and then I put a Fukuda retractor behind and just to gently lever the humeral head out. So there is nothing there. It's just a bit of patience. And as I said, not do it in extension, but in flexion and internal rotation, you can bring it out.
And you're using allograft or just an LT?
It depends on the size of the defect. If it's a small defect, then I'll just do a LT transfer. As I said, I now use a double row, sort of a speed bridge kind of anchors construct to do it, and that's quite robust. But if it was a bigger defect, then I would use an allograft.
Right. If the defect is too big, I would just like to ask again all the faculty. Let's say it's more than 50%, but it's theoretically possible. I haven't seen it, but it is possible after a year or so. And if you're going in, are you having a replacement at hand at the back trolley ready for that? I would just ask Tanna sir.
I have no experience of that.
Dr. Gawale?
I would consider, considering his age, I would opt for a rotational osteotomy. I have done about a couple of cases.
Okay.
The results are fair, good enough.
Rotational osteotomy without removing the LT or something? Or
plus additional procedure.
Plus a McLaughlin?
Yeah. No, not McLaughlin. A whole LT transfer.
Yeah, the whole lesser tuberosity goes in the defect.
Yeah.
Modified like McLaughlin.
Modified needs, yeah.
Yeah, needs modification of the McLaughlin, correct. Yeah. Dr. Jap?
Yeah, well, I think it's always wise to have a prosthesis on the back table, and it's a little bit depending on the age. If the patient is over 65, I would consider with the 50% defect to consider hemiarthroplasty. They do very well in this sort of cases, but in the younger patient, I go for the allograft. I never do a rotational osteotomy, actually.
Well, when you're doing a hemi replacement, you are obviously, making an alteration in the version, correct?
No, it just depends on your rehab. And you definitely, because the posterior structures are stretched out, so they're definitely unstable the first period. But if you use a brace in a neutral rotation and you have the patient strengthen the posterior structures, you never get it unstable.
Right. Dr. Hassan, anything to add in that?
No, I mean, I think I agree. It's wise to have prostheses available. I would probably have a stemless one available, and if I need it. But in a 50-year-old, I think he says patient 50-year-old, I would lean strongly to doing allograft.
Right, Dr. Kapil, anything to add?
I think what you said was if it was a year out, then I'll have a low threshold of doing an arthroplasty and have it available. Yeah.
So what I did was I just did a McLaughlin. So 2 screws medially and two anchors medially, screw laterally as a double row. So I did not use a anchor in the lateral part, used a screw to park the sutures, essentially a double row repair, transferred the LT or a modified McLaughlin procedure. X-ray is not very clear, I'm sorry for that, but that's why I added the CT. And this is few months out. The rotation improved a lot. Elevation 130, 140.
Nice function. Very good.
Yes, sir. So this was a regular modification of the McLaughlin, as Dr. Gawale mentioned, transferring the whole LT in the defect, not just the subscap. So I'll just move on. So next, so I'll just show you this case. So this is a pretty different case, and for some reason, these are the ones I've encountered more commonly. Just a very old lady, like a 70-year-old lady, and for some reason they've just increased in numbers recently. So 70 or 70-ish, 71, 72, or there was even a 65-year-old lady. So this one had a minor fall, like 40 days, not too much out, like 30, 40 days out of minor fall or some event that she recollects, but restricted movement since then. And now she presents with mild pain, restricted movements. But she, and now next step, would you get MR or CT or nothing? If you had to do one, I mean, would you, or would you get both of them? Tanna sir?
If one, I'll get a CT done. If it is two, then I'll get both.
If one, you'll get a CT only, and if two, or both of them, correct?
Yeah.
So CT is your preferred. Dr. Gawale?
If she is a young active, probably I would do a CT, and if she is inactive, I will ignore her a neglected conservative treatment.
So she's 70-year-old.
No, if she is active and her demands, activities of daily living are too much, probably I would consider a surgery. Otherwise, I will leave her alone.
Right. Pradeep, are you there? What do you say? What your take on this?
So I think that is the patient's expectation is going to tell you what treatment. Definitely, if patient wants his shoulder to back, then it needs to be reduced. And of course, she's going to have a lot of rotator cuff tear along with the dislocation as well. So that's
an MR? MR or CT?
So I think CT, MR means
or both.
Not only CT, because anyway, when we are going to open, we are going to see everything there. And reverse needs to be kept at the back of the mind if there is a very bad cuff quality.
Correct.
Otherwise, just a reduction and cuff repair could be okay.
Right. I'll just show you the MR, but the cuff was perfect though. Dr. Hassan, are you there?
Yeah.
MR, CT, do you expect anything?
Can you go back to the injury films? Yeah, I mean, I don't know that the CT really helps you that much, honestly. I think if I was going to get one study, I would probably get an MR. But and you said you have an MR?
Yeah, I'll show you the MR. But yeah, Dr. Kapil and Dr. Jap.
I have a question for you, Deepit. Why did she come to you after 40 days? Was the pain increasing or?
The pain was increasing. At first, she thought that this is something, like really minor and she will get better in few days. But, in 40, 45 days, she thought that, oh, it's not getting better. Let's go see a doctor. So that's how they think. But that's not the first case. I can tell you, I did 3 or 4 of them in last 2 months.
Yeah, well, if you consider surgery at all, then I would do an MRI. And MRI can give you also a good impression on the bone, but it definitely gives you idea about the cuff structure.
Right. Dr. Kapil?
Yeah, I would agree. I just, on the plain X-ray, there was something in the inferior part of the glenoid, whether that's a rim fracture or something, I'm not sure. Yeah. So, CT tells me about that. MRI, as you said, she's likely to have a cuff tear. That's the worst thing you can expect. But if you make a decision and you're going to do something about her based on her CT, then that will give you all the information.
So no cuff tear reported. The MRI was not very contributing. Did not expect a cuff tear. And I did, we opened it. There was nothing in the cuff. It was all perfectly okay. This has been...
Dip it on the MRI. She had no... atrophy of fatty infiltration or any of the cuff musculature?
It's only 40 days. Nothing. Yeah. And this has been the pattern in last 3-4 cases. Cuff tear, I always expect dislocation. An elderly would tear off the cuff. It's just so fragile, and most of them do, but these ones are not tearing off the cuff. This was so now if you're going in, would you attempt close reduction, Tanna sir? At 40 days, would it be possible? No, Dr. Gawale?
No, it's not possible.
Nothing. Okay. Pradeep, Would you? Nothing, not even one try?
No.
No. I heard somebody say it is possible till 45 days. Dr. Jap?
Well, I would not dare it, to be honest.
No? Okay.
If you
Dr.
get a
Hassan,
fracture, you are in a serious problem.
one go at it. Dr. Hassan, anything? No?
No.
Dr.
Close
Kapil, do
reduction?
you
No.
remember we had this discussion and I think somebody had said, no, it is possible to get it till 45 days.
Not at age this
That's
age.
ambitious.
Yeah. Dr. Kapil, do you remember that?
I would, in a 70-year-old with osteopenic bone, I would not attempt a closed reduction.
Okay. So now this is a cuff is all okay. Can I go one by one? Tanna sir, would you care to comment on this? A surgical approach, steps in open reduction, precautions, and period of immobilization.
It's the standard what we have discussed in this particularly elderly lady. I would also try to mobilize as early as possible, depending upon the stiffness about the instability part, what is there afterward. If it is not much unstable, in about 10 days time, I start mobilizing.
After open reduction.
Hey, Dipit, can I ask a question? Is there axonal nerve working?
Yeah, it was all okay. Right. Dr. Gawale, would you care to comment on this? Surgical approach, steps, precautions, and period of immobilization. Would you immobilize more or less?
Since you're insisting on the time limit of surgical approach, probably you have done a close reduction and you have got away with it.
No.
So apart from what has been discussed, Pradeep has summed up release of the rotator interval, tenotomy of the biceps, and then, your reduction is quite easy.
Right.
Immobilization depends on on-table stability, how good you have achieved. Otherwise, just a sling and mobilizer immediately.
How long would you immobilize?
May not be required if it is stable on the.
Right. So, Pradeep?
Yeah.
Would you just comment on the precautions and period of immobilizations?
I think again, we can start passive range of motion as early as possible.
Immobilizer for how long is my
it all
question.
depends on it. If the cuff is good, we can start as soon as we can start passive mobilization as soon as post-op pain is gone.
But would you remove the subscap, and if you've repaired it, would you still mobilize it?
That's what I'm saying. If the cuff is everything good, if you can manage just only with rotator cuff interval release, then we do not need much of a mobilization. We don't want basically at this age.
Dr. Jab, would you expect anything else?
Well, depending on if you have reduced it and even with the repair of the subscap, if it is stable, you can start early passive mobilization, but still I immobilize them. But if they are with a little bit of external rotation already dislocating, then I would be very careful with my rehab.
Right. And surgical approach stays the same?
Yeah, delta pectoral and rotator interval, and if needed, detach a little bit of the subscap, but basically quite often it is not needed.
Yeah, correct. Dr. Hassan, anything to add?
Yeah, I mean, I think, you got to make sure the biceps is not dislocated and incarcerated and blocking reduction, because that can definitely happen in these cases. And I guess the other question, as Dr. Kapil noted, there is some inferior glenoid irregularity, and I guess the question arises, does that need to be addressed, to reef the capsule and repair that small bony Bankart? So I think that, once you reduce it, assess the stability, I think at that point, if you feel like you need to do it, you could do that through a subscap split and get into a subscap split and repair the capsule and repair the bony Bankart if necessary.
Dr. Gawale, you're trying to say something.
Somebody had pointed out that bony fragment near the greater tuberosity, and going by the dictum, anterior dislocations, they are associated with greater tuberosity fracture. So was that representing the greater part of the greater tuberosity in the first X-ray?
This one?
Yeah. What is that? I think somebody pointed out it is a part of the
glenoid.
Yeah.
So maybe a small chip at the glenoid. but not the greater tuberosity. So I'll
Is
just
that
move on. I'll just show you. So we just opened it, reduced it through a subscap split approach. Of course, removed the biceps, opened the rotator interval, and nothing else was needed though. No subscap split was needed. Those are pretty lax, and it wasn't. It was only 40 days old, so it's still possible to do it with not an extended approach. Means not removing a lot of soft tissues, going either through the rotator interval or subscap split, either one of those, and you can still get it back in place, immobilized for 4 weeks. I'll just move on. This is the last case. So this is a complicated case. I'm just adding it for completion's sake. So this is a known case of rheumatoid arthritis, 65-year-old, partially independent, but she does have a lot of pain on the left side. The right side is not so much painful. She has dislocated both the shoulders. She has big cuff tears on both the shoulders. She is few months out. She doesn't even remember how many, but few months out. She does say few months, maybe 3 months, maybe 4 months, but definitely not acute. And if you see her right side is going up. The right side is going up. She's only mildly painful. Left is very painful. It's not adjusting. Left is horrible. Left, she is really crying in pain. No rotation, no elevation, very painful. Right, she's okay with right, but dislocated both shoulders, both of them. So can you leave any or both sides neglected because of old age? She has a cuff tear, massive cuff tears. Tanna sir?
The right, I leave it alone. On the left, which is very painful, as
Right.
you described.
So reverse shoulder, anatomic shoulder.
Reverse shoulder.
Right, and expected complications, functional improvement.
Range of movement will take a long time to come, but it will be stable.
Right, Dr. Gawale?
you have already done that?
I've done that, but I'd like to have all your opinions. Would you operate both the side, one side or no side?
Painless. She would be painless on the left side.
Right side, you would leave it, right? Okay. Reverse, obviously, correct? Not anatomic?
No, reverse.
Reverse. Okay. Pradeep,
Yeah,
would you agree?
I would actually send her home because her treatment is not going to be different if we do it for a month or two later.
Right.
So I want her to ask for the surgery rather than me suggesting it, because at this point and with such bone, we do expect complication of the reverse shoulder also.
Correct.
So
and you see the AC joint is gone too, both sides.
Yeah.
Destroyed because of rheumatoid.
So if the time is doing the thing for us, then very good. If not, then we can intervene a little bit late, does not make much of a difference.
Right. Dr. Jap, Dr. Hassan and Dr. Kapil, anything to add? I'll go with Dr. Jap first.
Yeah, well, if she's that extreme painful, I think I would advise her immediately to have a reverse arthroplasty. Leave the right side and operate on the left side.
Correct. Dr. Hassan, anything else different?
No, I would agree with that.
Okay. And Dr. Kapil?
No, agree with that. Yeah.
So this is just did a reverse on the left. I did not touch the right one. She's painful. She's painless on the left now. She has a good range of movement.
Wow,
but
very good.
So yeah, around 160 degrees of elevation. Of course, AC did not touch at all. It is not painful as of now. AC is not painful. The right, she's not complaining, but the problem has now gone to hips. Her hips are destroyed. So she is getting the hips done, and knees are already done. So it's the knees, both hips, left shoulders done. Right is remaining, which I'm not touching. Yes, Dr. Gawale is saying something. Yes.
What's wrong with the glenoid? We see a superior distance between the base plate and the glenoid.
Right. No, I lower my base plate extremely low to get a desired lengthening. So this is, you'll see some distance on top, and this is a small base plate, like 25 millimeters. So a normal base plate is 29. I'm using 25 on the lower part of the glenoid. So superior part of the glenoid sometimes is left untouched, but it is coinciding with the lower glenoid margin. That is just a technical thing. Yep.
So how much did you lateralize her?
This is, the Biomet normal. It's not the lateralizing reverse. It's the medialized. It's just the Gremon design.
Yeah, we may need to take other X-ray because that might be just the coracoid there. What we perceive as a glenoid, it might be just the coracoid because otherwise we cannot make coracoid anywhere else.
Correct. Yeah, so cemented it. She's pretty good right now. Right side, she has limited movement, but she's very very mildly painful on the right side. Did not touch the mild right side at all, and she's not even asking for it.
So, one thing on these rheumatoids is that, the risk of complications and them are significantly higher, right? They're bone loss and osteopenia.
Correct.
So for these, I really try and minimize. So I definitely I do Vermont, and I like an inlay humerus, as opposed to an onlay humerus. I mean, there's some evidence to suggest that, onlay humeruses have a higher incidence of coronal stress fractures. So, I mean, I think this is fine, looks fine, but I think that, that's just something to consider,
right?
To make them, as the detension of deltoid as much as possible, and keep it the same within keeping it stable, of course. But
and the because of the acromion fracture, would you say? Are you afraid of that?
Yeah, well, acromion fracture and just in general, anything that avoid any lateralization at all in the glenoid to avoid stress risers and potential failure on the glenoid side.
Right. I'll just sum it up. So open reduction of anterior dislocation can be attempted with due precautions. Treatment of posterior dislocation neglected has good prognosis. Neurovascular should be kept in mind, and if not painful elderly, we can leave some of them untreated. And we've published a paper also in JSCS reviewing everything, passing our recommendations on the neglected dislocation. These are the recommended reading. I'll be posting it on the chat, and we'll be sending the PDFs for people who want to read up on the neglected dislocations. Good read, all of them. One of them is a landmark paper by Rowe and Bertram, Rowe and Zareen. This is a very old paper, but a classic paper. I'll be adding that. Thank you.
Thank you very much, Dipit. Can you stop sharing so we can? So this brings us to the end of today's session, which has been really informative, and we have almost still 120, I think. 105 people still watching. We started with 140, and that is good retention throughout the course. I thank all the faculties, Dr. Ashfaq Hassan, Yap Williams, Dr. Kapil Kumar, Dr. Sangeet Gawade, Dr. Tanna sir, my co-convener, Dr. Dhaval Desai, Dipit, and all the officials of BOS, Dr. Zaveri sir, Swapnil Keni, Mandar, and this has been really a good session. Over to you, Dr. Zaveri sir. Hello.
Thank you very much, Pradeep, and thank you very much, Dipit, for convening such a fantastic and informative session. For all of us, we've been learning. I am a spine surgeon, but I too have learned a lot just watching this whole session, and I threaten all of you that I may start practicing shoulder soon.
we will get a far better complicated case.
It was extremely enjoyable. I thank all the faculty from India and from abroad for this fantastic session, and a special word of thanks to the audiovisual team of the Bombay Orthopedic Society, Dr. Kshitij Chaudhary, Dr. Swapnil Keni, and Dr. Mahesh, who have done a fantastic job with this telecast. Let me again end this broadcast by reminding all of you that WIROC 2020 Unlocked is around the corner. It is in March. Please do register. With that, thank you very much. If you have any questions on any aspect of today's webinar, please feel free to approach Dr. Pradeep Nemade and Dr. Dipit Sahu through their email or their WhatsApp chats. Thank you very much, and good day and good night.
Great.
Yeah, that was awesome.
Thank you to all the faculty.
Very good.
Anna sir, Dr. Gawale, Pradeep, thanks. And thank you, Dr. Hassan, Dr. Kapil, and Dr. Jap. Great to come here and enlighten us. Gawale sir is our next president-elect. Thank you, sir.
All the best. Thank you. Bye-bye.
Thank you very much.
Yeah.
Bye-bye.